Good morning, everybody. I'm Allison Agu. I'm an associate professor of Adult and Peds ID and one of the co-directors of the Adolescent Young Adult Scientific Working Group here at the Johns Hopkins CFAR. I'm delighted to have you join us today. A little bit about how this came about. Lucky to have Tanya Wei, who's going to speak in a few, who I've known for a long time, who works as a Peds HIV expert in Thailand, and the network of people talking and her coming for a visit, that we thought this would be a perfect opportunity to have some dialogue about what's happening, not just here in Baltimore, what's happening in Thailand, and how the exchange between our sites can help educate us all and move the needle in terms of PrEP for adolescents really worldwide. So nice of you to join us, and we hope that this is not just us talking, but we really do look to this to be an exchange and a dialogue to hear what your thoughts are and weighing in on how we think and shape our ideas. All right. Some housekeeping for those of you who don't live in this building. The bathrooms are out to your left. The stairs are down that way too. Hopefully you won't need to exit as part of a fire drill or anything like that. All right. So I'll start by introducing Tanya Wei Patanakit. Tanya Wei is Associate Professor of Peds, Infectious Diseases at Department of Pediatrics, Faculty of Medicine, Chulalongkorn University, and investigator of the Thai Red Cross. Now, she's a former trainee of the Johns Hopkins University Fogarty AIDS International Training and Research Program. She truly has become a leader in pediatric HIV treatment and care in Asia, leading multiple multi-center research programs in Thailand, Cambodia, Indonesia, and also collaborates with Treat Asia Research Program. She has authored more than 100 peer-reviewed publications, and really you Google HIV, adolescents, pediatric, and Tanya Wei's name comes up. So it's really nice to have her here. In the past 3 years, she has set up a cohort of newly infected HIV adolescents, mostly among young MSN, and set up youth-focused services to provide HIV testing and preventive packages, especially PrEP, for young MSM and transgender individuals in Bangkok. Her career goal is to support AIDS-free generation, start free and stay free in Thailand and Asia. Please join me in welcoming Tanya Wei.
Okay, good morning and sawadee ka. So it's my great pleasure to be here today. Actually, I was here as a student almost 20 years ago from the Fogarty AIDS program with Dr. Chris Barrett, Craig Hendricks, and many staff here. And at that time, when I came here because of the problems in pediatric HIV in Thailand, at that time, the transmission rate in pediatric is still high, about 8 to 10%, and there are literally no antiretroviral drugs at all in Thailand back in 2000. And in the past 2 decades, I think we do a great job in curb down epidemic in pediatrics population, and also they are growing into adolescent. But now we have another groups coming, which might be similar to what happened in Baltimore in US, that is young adolescent MSM is coming. So what I would like to do is to share the experience and the situation that we have in Thailand and Asia, and also show you some data of the PrEP rollout program in Asia and also in Thailand, and also talk about the challenges in youth integrated HIV prevention services that we try to set up in Thailand, that based at the Thai Red Cross AIDS Research Center, which is in the same medical complex at Chulalongkorn University. And also we do some work with the community-based organization, try to catch this adolescent into our services. So this is a little bit of background of HIV epidemics in Asia and Pacific, which is the second most hit after Sub-Saharan Africa. And in early 1990s, it's about more than 1 million newly infected HIV in Asia. And in year 2017, the number is bring down to about 280,000 people newly infected. But it's still about 3 times higher than the target of less than 100,000 people infected in Asia. So where are they and who they are and how to bring down these gaps? So the panel on the left, on the right of your side is on the distribution of new HIV infections in Asia. And I think it's divided into 2 groups. The first one is from the countries which have like 1 billion of population, like in China, India, or like Indonesia, Pakistan, which even though the number is high, but it was less recognized because when you divide it by the number of population, HIV seems like a concentrated epidemic in some certain population. So there's not much progress in terms of HIV treatment and prevention in that big country. For the lower group is the country size that range from about 30 million people in Malaysia to about 100 million people in Philippines, which contributed about 10,000 population newly infected each year, which this is the focus of my talk because that country still consider HIV as public health problems and have some programs going on. And this is the figure showing that what is the new HIV infection in Asia looks like. And this is the red bar is the proportion of young people, 15 to 24, infected with HIV. And Thailand, Indonesia, Myanmar, and Philippines, more than 50% of new infections occur in young adults. And all of them, it's from the MSM population, except for in Myanmar that also have people using intravenous drug use that contribute to the new infection. So if we would like to close down the gap, we have to really focus on young MSM in these countries. And this is the change of epidemic in Thailand. So in early 1990 is more, the key population is more on the male client of commercial sex workers, which contribute to about 60% of the new infection. But later on, when we have 100% condom use, the number of new infection is come down. But actually it's too late because it's already go through the general female population and then transmitted to baby in the period of millenniums during that 10 years. But now it's going back shift to the MSM population, which now contributed more than half of new infection. And by the year of 2018, the number was reported as new infections, which we believe that is underreported, is about 6,000 people newly infected. And if you compare with the US, because Thailand have about 20% population comparing to the US. So the new infections is quite similar to the US, that you have about 30,000 new infection per year. And the epidemic is quite similar, it's focused to young MSM populations. And even though Thailand has a successful story of the first country in Asia, or the first country in generalized epidemic that have validation of elimination of HIV mother-to-child transmission, which is the goal of start-free generation. But when we look at the reality of the number of patients registered in the National AIDS treatment program, you can see that the number of youth starting from birth to 24 is rising all the years. So it means that we are not good at stay free. So even though there are only 60 babies born with HIV each year, but we have about 3,000 adolescents new coming in the populations. So this is the number of prevalence in young MSM-TG in several clinics. The first clinics is where I work at the Thai Red Cross because we have a large VCT center, and it's called anonymous, so people can come in whatever age and identity because they don't need to identify themselves. And also in Thailand now, the HIV testing can be done without parental consent. If you are 13 and above, HIV is similar to STD, that you can consent yourself to get testing, treatment, or prevention. So in our program, during the beginning of the year, March to May 2018, they have about 900 young MSM and TG come from HIV testing. And the prevalence is 7.5%. And we start to have a pilot program, try to roll out PrEP, but the uptake of PrEP, I think it's because of the capacity that we just started the program and also the understanding of the adolescent about PrEP is still low. So among 861 people who come for HIV testing, which means that they are themselves perceived that they have risk and walk themselves to our clinics, we can start PrEP to about only 3.5% of them, so we need to scale up more. And in Chiang Mai, which the Piman Center, which is the HPTN, HVTN site, they're also taking care of MSM, but a little bit older, 16 to 24. The prevalence is 9.2%. And at Siloam Clinic, the CDC clinic, it's much older population. The prevalence is 21%. So it seems like whenever they start to have sexual debut, the instances occur very early on in the first 2 years when they start sexuality exploration. So the second part, I would like to talk about the PrEP rollout program in Asian countries. So in US now, you have more than 250,000 people on PrEP. But what's going on in Asia Pacific, it's only about 28,000 PrEP users. And half of that is occurring in Australia. And another 10,000 is more on Southeast Asia, which is majority is in Thailand and Vietnam. So if you Google and try to find where can you get PrEP in Asia and Pacific, you can go to this website and they will locate where is the clinic that you can get access to PrEP. And also they have a PrEP online, which is at the Pulse Clinic in the downtown Red Light District in Bangkok that can provide PrEP online. You can buy it, and it's also distributed in other countries in Asia. But what do you think that adolescent can access to this? I don't think so, because it's quite expensive and also need to have like a high educated to get on this PrEP online. So what are the program in Thailand? So in Thailand, we start PrEP program in the past 4 years. The first one is called PrEP 30, which you have to pay 30 baht or $1 to get access to PrEP and testing. And then it's not work because they need to pay. So we changed to Princess PrEP, which changed the Princess donation money from PMTCT shift to any prevention services and using key population-led service. And now the next step is the MOPH PrEP to start, which they try to convert the HIV treatment center in order to also provide HIV PrEP service too. And it's start to located in about 25 provinces in Thailand. And the last one is our program, Youth PrEP, that we would like to target 15 to 19 populations. And so far, we hope that MOPH will announce the PrEP under universal health coverage later this year. And this is the site of PrEP in Thailand, which I'm not sure whether it's work or not because it's used the HIV treatment center. So it means that usually when you are sick, you are motivated to go to centers. But if prevention, I think we need to find them out in the community rather than waiting for them to come into clinics. But at least it's start to have a conversation of healthcare workers prepared to roll out PrEP in Thailand. And this is the program in Vietnam. Vietnam is also funded by USAID. And so far, they have about 2,000 PrEP users in Hanoi and Ho Chi Minh. And they target to expand in 11 cities in the next 2 years. And this is from Philippines. Philippines is even harder because the MSM is very have barriers to identify themselves. So this is a program run by the NGO called Love Yourself. And they use Pokemon Go. Have you played Pokemon Go? And they say that because it's even very hard to find condom. So they set up Pokemon Go to identify where is the safe place for you to get condom. And also after that, transform into HIV testing and PrEP service site. And I think the concept that they have a campaign is to saying that it's in the terms of branding that is for your health and also to stay healthy. It's called Love Yourself. It isn't just about HIV, but also increasing person's self-worth. And they just have about 200 clients in their program. And this is also in Myanmar, which I think I know less than you and Andrea about what's going on in Myanmar, but they also have to start a program of PrEP in IVDU population. So the second part of my talk is talk about challenges in youth integrated service that I provide service in Thailand in terms of awareness, access, and also adherence. So in awareness, I think in youth, when I talk to my kids who are in the middle school, what you taught about HIV in school, they say that we still learn about AIDS. We don't know that HIV can be prevented. We still find that it's quite a deadly disease. So we talk to medical students and some groups that we need to bring out this campaign. So part of the HIV Run campaign that we do, we try to motivate young people to provide more information on PrEP, on the activities, and also online to give more information. And also HIV not equals to AIDS, so they can understand about you can prevent them from getting AIDS or develop into AIDS. And also HIV testing actually can be done without parental consent and free of charge twice a year under universal health coverage. And also PrEP as a prevention tools. And now we talk with Hornet, which is dating app, which have about 1 million users in Thailand, and try to have them help us to to talk about PrEP and also how to link it into the services. And when we set up the program, we use our strength that we have in 5 domains. The first one is on HIV VCT Center that's anonymous, and it's have a well-known that it's safe place to come, and a lot of adolescents come. And double cascade services that if they are tested positive, they will have rapid ART initiation within a week. So they feel comfortable that whether the answer is positive or negative, they can have further services. And also we provide STD, mental health, and gender-affirming health care. And because we are Thai Red Cross, it's a donation program, so they can come in free of charge. And also we have a research center to have case manager to help them. So this is our clinics that we provide them, which is a flexible hours, and they can book online or have contact and get consultation anytime, which we have a very high peak load after Valentine or Songkran festival or long holidays. And the service that we have also includes psychologists, psychiatrists, colorectal services, and also substance addiction. And the referral beginning mostly refer from the VCT, and now the STD treatment centers also refer patients to us, and also from dating apps. And now our program is about a year ago, so now they are refer friends to our program. And this is an example of cases that come into our clinics. 18-year-old MSM resent sexual risk, have sexual debut for about a year, and have condom use about 50%. And they just come and ask for prevention service. However, when we get tested, they are HIV negative but not positive, so they are acute HIV infection. So after we call them back and get HIV blood testing, there's confirmed that they have positive. So we provide treatment immediately. So one of the key that adolescents come to us because they know that our center will screen for acute HIV infection. So sometimes they just come in for, I have a risk a while ago or yesterday, so what should I do? And the second one is 17-year-old transgender woman. She's client in our centers, and she was ringing us on 2018 that she has unprotected receptive anal sex last night, and the counselor asked her to come in and pick up PrEP. But at that time, she didn't pick up because she's afraid that she needs to pay for the cost. And then about a month later, she developed acute retroviral syndrome. She had fever, malaise, transient rash, and have anti-HIV positive, which I think the access and free of service is really needed for adolescents. And this is the price of the service that they need to pay. The HIV testing, you can, if you use the national identity, you can get it for free. But the STD screening and treatment is also quite costly. And also PEP and PrEP cost is also costly. And now that the generic TNO-EM is available, and now bring down the cost to about $12 per month. And the last one is 16-year-old MSM comes with his partner. His partner is 30 years old and just disclosed to him that he was positive and was treated. And they are sexually active, and he would like to get PrEP. But I think this one is quite a good position because his partner bring him in and have motivation to take PrEP. And this is a gender-affirming healthcare for transgender women, which was established by Dr. Nitya. And this is bring in the hormone as a magnet for transgender to come into the clinics and HIV testing. And now we try to also have a specialized team to also taking care of young 15 to 19 transgender women. Yes, when she visit us, yeah. And we also use the mental health screening that we use for HIV positive adolescent to screen. Also the people at risk who are coming for prevention. And we also have a social worker and case manager in our team try to triage. If someone have problems, we refer them to a psychiatrist. And we also have 2 projects called Enhanced PrEP Adherence. The first one is the Raincoat, which was funded by CIPHER, International AIDS Society, that we developed a program try to address 3 things that to help them to understand and perceive their own risk by entering information, repeated, go through their risk, how many times that they use condoms, and how they adhere to PrEP regimen in order to identify themselves about risk, and also have a reminder on the app to help them take PrEP. And also, if they take PrEP properly, come to clinics, get anti-HIV testing on time, they will get rewards to get cash out, or they get time on internet to be socialized with their peers. And I will show you more about the result of this program. And then another one that we linked with Lisa and Sarah at Duke and North Carolina is called P3, which will launch in US, but we also have P3T, which is P3 in Thailand, that we optimize to use it in Thailand. But that one is have a different platform. That one is more on the social networking and community to have them know the lifestyle of friends or peers who live with using PrEP or involved with HIV prevention package, and also have some games to make them adhere to the program. And we are about to start that in August.
Lisa.
Yes, Lisa. And also we think that it's not just the app or how to engage them. We have a focus group with adolescents, and they say that they need someone that they can rely on, non-judgmental, and they can contact, at least we will actively contact them monthly, but they can contact us at any time. And this is the example of the mobile app that we use. This one is Raincoat, and it's the concept that you can key in, the first one that you can key in the number of how many PrEP, how many sexual activities you have, and then it will turn in the colors that you are in green, yellow, or red to understand what is your ongoing risk. And also have a reminder of how to take PrEP and also reminder of when to come back to clinics. But for P3T, it's more on the chatbot, avatar selection, that they can present themselves in the community of adolescent. And this is the result of our program that we conduct in 2018. So far, we have about 130 adolescents in our program. But the data that I show you is analyzed by the time the end of December for IAS abstract. So it's about 100 adolescents in our program. So we provide a daily PrEP, condom, HIV test every 3 months, and also provided as a youth-friendly service that they can come in the late afternoon or at a Saturday morning. And we contact them in person and also phone contact at least monthly to keep them engaged. And this is the demographic of participants. About 269 screened, 98 enrolled, 13% is transgender and 87% is MSM, and about 20% is 15 to 17 and 80% is 18 to 19. The median number of sex partners is about 3, median number of sex acts is 4, and any STD at baseline is about 29%, mostly GC, syphilis, and chlamydia. And also about 20% of them use alcohol and substance abuse. Majority is crystal amphetamine or ice, and amyl nitrite, popper, and also methamphetamine. So we also try to figure out how to deal with this one, which I think we need some suggestion from you about how to provide HIV prevention on the population that they use quite a lot of substance abuse. And this is the PrEP retention in the past 6 months. I think the first 3 months is quite good, and then after that it starts to drop. And one of the reasons is that they say that if they are not engaged in sex, because I think they are still have a period that they're not at risk, so sometimes they're not coming. But we said that as long as you can come back at us anytime. We just care about retention, not adherence on the medicine that you received. And also, after we discussed with Chris about how to analyze this data, because it's not the same as people who are on treatment that we need 100% adherence. So with that app, and we can identify at risk per week. So among the follow-up time, about 28% of follow-up time, they are sexually active. And 8% use condom only, 100% condom. And 30% use PrEP more than 4 times a week. In blue, it's 38% use both PrEP and condom. So we left out 24% that is not well protected by either condom or PrEP, which to me, I think it's quite acceptable in terms of the adherence of the program for adolescent. And we also have a measurement of TFP-DP on dry blood spot. So comparing to ATN data, about 50% have more than 700 femtomole per punch by week, I think week 24. Yeah, but in our program it's about 39% above 700 and 22% about between 350 to 700 femtomole per punch. So I think we need we need to improve a little bit, but so far I think it's quite acceptable. So what is we learned from the program is that good rapport is key to retention, because I think we are come from adolescent treatment, that we are quite what is called tolerance to not taking medicine but just come back. It's the key. And we have non-judgmental and collaborative problem-solving approach, sit with them about how to make it better, and also have flexible services and integrated service. This is the one that Adolescent is highlight. They said that whenever they have any problems, they just come to the same provider, and then we refer them to mental health, or even we go into the jail to provide them continuous support when they get caught because of the drug abuse. And also they start to help us on peer-to-peer recruitment and find more at-risk population in our program. So I think the challenge and way forward is how do we scale out this program in Thailand, because we are another program by UNICEF that just start to roll out 15 to 19 is very few in Thailand that would like to focus in this quite difficult population. And but at least in Thailand, the legal policy is also open up that we can test under 18 and provide treatment. And also PrEP awareness among youth, because when we have a campaign, they say that they just know about postcoital pill. They don't know about PEP or PrEP. So it's still a way to go to educate people about this modalities of HIV prevention, and make sure that it's accessible, affordable, and have a program to adherence to the long term. Because I think at the beginning we thought that they will be at risk for 2 to 3 years. But after I talked to Professor Suwat, who do IPREX, he said that even after IPREX, they're still on PrEP or need HIV prevention for another 5 years. So he said that if we start program in adolescent, we need to aim for retention or persistence at least 5 to 10 years, not just a certain period of time until they get through the process. So I think the long-term management is very critical. And also how to build healthcare worker skills and service delivery. Because in Thailand, some of the program, they just would like to do treatment and don't want to deal with prevention because it's overloaded. Or some programs, they have a willing to do adolescent, but it's just during work office hours, which cannot be done. So we have to have a program to have funding to really have a prevention appropriate for adolescent. So in conclusions, I think now we see that in Asia, in many settings, like in the US, that new HIV infections in adolescents overtaking perinatally acquired HIV. And we have to think about how to scale up rapidly, including overcome barriers in terms of legal, age, stigma. Because in our program, we also have many adolescents that are not telling about their sexuality in the family, so they don't have adult that they can rely on. So they need a program that really understands them, and also integrated services, including STD treatment, mental health, gender affirmation services, and it needs to be free of charge in order to provide service for adolescents. I'm not sure yet which service delivery models will be suitable, but I think it have to be different model. Can start at a VCT like in our program, or start at the STD clinics or ALV clinics, because I think many of pediatric programs who have experience dealing with adolescents, who have a mind to really care about adolescents, still be able to ask them to put on more effort to also welcome the coming adolescent up to 24. In Thailand now, it's just only 18 that can be acceptable to be in pediatrics clinics, but because we don't have adolescent medicine at all in Thailand, so we try to ask 18 to 24 to be with pediatrics program. And in order to have HIV stay-free generation, we need to really tackle at the time at risk to prevent them from HIV infection. So this is the acknowledgements of our team back in Thailand, and also the international collaborators that we worked with in the past 3 years. Thank you very much.
Thank you so much, Tanya. I think we have some time for questions.
Tanya, we're being formal.
Yes.
Can you talk a little bit about your success in peer-to-peer recruitment? I know we're going to hear from Andrea, and she knows all about our problems, but how are the peer recruitments doing in Bangkok?
So there are from the sexual network, and also they start to write it online on their Instagram, on their like dating app or some information to review the restaurant, something like that. That this is a place that you can come in and get services. But it just start a program, and I think one of the issue is that when we try to disguise ourselves in the dating app or in the adolescent website, they know, and we was kicked out. So we try to have them to be the person in that network and then refer peers to our program.
Carlton.
Good morning. I would like to understand, you mentioned about the stigma. Is the stigma also caused because of religious implications for gay men to be who they are in Thailand or amongst their families?
I think religious is not quite that strong. I think Buddhism is not quite strong on religious, but I think some culture like Chinese culture, Chinese, they are like very male predominant, and if the family have a son, they're quite hard to accept that there will be MSM, and also some in general some stigma on MSM is still there in Thailand, and I think adolescent is then quite. It overall sexuality is not open up and talk among parents and adolescent in families. So it's hard to tell that they also start sexual debut and also their MSM in general in Thai culture. You want to add something on that, Chris?
No.
You know Thailand for for a long time.
This was wonderful, thank you. I was curious if you could talk a little bit more about you had the two platforms. Yeah, one was the Raincoat, and
Yes.
then the other one was more of a gamification app. But it sounded like there was also a piece that existed where there was a chat room on that. And I wanted to know if you could talk a little bit more about that and who was actually leading the chat room discussions, how you were able to monitor those, as well as provide some ethical and confidential protections for youth, which we often are challenged with here in the US.
Yeah, so the raincoat is the one that I show the result. That one, when we start a program, we not use online because we are afraid about confidentiality. And also the app was developed in Thailand and we have limited budget. So we use offline, and we think that offline is somewhat a benefit in terms of the confidentiality. For the P3, we not start enrolling yet. We're about to start, but we in the process of focus group and talk with adolescents about how to use it. And they say that they can talk at chat room, but they prefer to be in avatar, not present themselves as it is, in order to be somewhat protected in terms of identity. And also we find some major difference of adolescents who come in at Thai Red Cross clinics is the one who are not open up that they are MSM. But if they are open up, they will go to the RSAT, which is the community-based organization for MSM and TG. And I feel like that we have to have both type of services, because if they are still not open up, they are afraid to go to RSAT services. They are preferred to be kept confidential and private in our program. So I think your point is that the confidentiality and identity is very critical to be very careful.
I was just going to say, Carl, to answer your question about stigma, that you'll hear a little later. We also have a prep program with young MSM, 18 to 26, and there we've had a number of social harms. And virtually 100% of them relate to HIV stigma, not being gay, not being trans, but really a confusion, a conflation of PrEP, and particularly with studied drug. as an indicator that somebody has HIV. And the
Yeah.
HIV stigma in Thailand
It's
is very
still there.
persistent.
Yeah.
It's very persistent. Actually, the question I want to ask you about is just to talk a little bit about, I think when we look at your population and the sexual risks, and this is true now for a number of programs, maybe even more so for adolescents in other settings, we're basically giving people really only one option, which is the daily oral PrEP. And at least for men, adult men, in Europe, we have very good data that on demand, the 2-1-1 schedule is equally effective. And for the adolescent boy or young adult man who has less risk and has maybe 3 sex acts a month, this may be an option. Some people don't want to be on daily PrEP, and I think it's, in my view, is a potential to address this problem of persistence. So we've talked about that
Yes.
a lot. So maybe you just want to speak to it.
We also asked them in focus group about what do they think about daily or on demand. And what we find out is that if they are young, they would like to do daily because they say that they don't know when it's going to happen. So they don't need to think about how to use it. And it seems like to me is that the one who are moderate risk, they are not well controlled about their sexuality, so they prefer once daily. But someone who older or have more sexual partner, when we see in their app that they make note about how to use condom and PrEP, we can see that some person have a period that they use PrEP all the time, not use condom, and some period they use 100% condom and not use PrEP. So it seems like if they can navigate of how to have how and when they have sex, and then how to use each prevention domain, it's good. So after we have that discussion, so we think that probably young adolescent, it's too hard for them to figure out how to use on demand. But they prefer to use interrupted PrEP. So they said that in this semester, I study very hard, I don't have any boyfriend, so I decided to, is it okay if I decided to stop in this 3 months, and when I have a relationship, I will ask you again about how to start and when the PrEP will be effectively in my blood that I feel safe. So I think in my opinion, young adolescent in our setting is more on the continuous PrEP interrupt if they are not at risk and then come back again, rather than on demand that we talk about as in the Europe.
Just a quick comment. I think that speaks to the relation between the team and the youth, so they can have that exchange. And I think when we're so dogmatic about this is what you do, and we're so disappointed if you don't use it, then they're less likely to tell us when they're going to make those modifications. So, I love that we're asking them and they're letting us know. And as long as we're open, I think we're going to get what actually will work for them. I did have one question for you. When you talked about the enrollees, you had 269 screened, but only 98 enrolled.
Yes.
I'm curious who screened out or who decided not to. Just can you take us from the 269 to the 98?
Okay, so 269 is from the counselor. So in our clinics, people will come in for HIV testing, and if the counselors feel like this one have high risk, they will start conversation with them whether they would like to use PrEP or not. And then some of them is interested and then refer to get PrEP service. But some of them said that, okay, this is the first time I learned about this, let me think about it and we'll come back. Okay. So that one is the one who will not start conversation about PrEP. Okay. And I talk about the HIV stigma that you mentioned. That is true, that they are quite very afraid that someone will find out that they have blue pill in their pocket. So they have to hide, because when they see that they take something daily, it's somewhat disclosed that they are related to HIV, whether it's prevention or treatment. So they are very afraid that they will find out. Yeah.
Time for one. Go ahead.
Yes, Tony, one more question. I thought about, you mentioned that 39% had the detectable or protective blood levels for tenofovir.
Yes.
The ATN 110, 113 had about 50% at 24 weeks. However, in African American men who have sex with men, they had subprotective levels at all time points. Mm-hmm. Have you looked at any differences in protective levels in any of the groups that you're seeing, whether it be, I know that this was all in one particular population, but are there ethnic variations that might exist, cultural variations that might exist, age variations, even sex work or risk variations that might exist, to seeing differences in protective levels in your population?
Because the number is still low, it's about 49 samples. We plan to do when we get the next batch results come back. But what because in Thailand it's not much in terms of the cultural or ethnic difference, but we would like to look into subgroups. The first one is comparison between transgender and MSM, and another one is younger age and older age. Yeah, but we plan to do subgroup analysis when we have enough data set.
All right. Thank you so much, Tanya Wei. Please give her another hand.
Thank you.
And we'll have a chance to do much more talking later. Next, coming to the mic, I'd like to introduce Angie Woods, who is a faculty member in the Department of Epidemiology and the Center for Public Health and Human Rights at Johns Hopkins School of Public Health. Her research focuses on international and domestic research and implementation science related to HIV and gender-based violence, with particular interest in underserved populations. She is a principal investigator of the LIGHT study, a technology-enhanced multi-site cohort to assess risk of HIV acquisition and other health outcomes among trans women in eastern and southern U.S. At Hopkins School of Public Health, Dr. Woods instructs graduate-level courses on health survey research methods and the use of epi methods to document human rights violations. And her talk today is recruitment of young gay and bisexual men and transgender women for PrEP research and programs. Thank you, Angie.
Thank you. Good morning, thank you. Is it working with the mouse? Or the clicker? Great, good morning. I'm happy to come and speak today about some recruitment options that we have available for the recruitment of gay and bisexual men and transgender women, both here in Baltimore and broader US, but also that has been ongoing in Southeast Asia as well. So a little bit of background context. This really comes in light of the high and persistent new infections among youth, particularly gay and bisexual youth and men and transgender women, and particularly among racial and ethnic minorities in the US. Dr. Tanya Wei highlighted the similar rates in Thailand as well as Myanmar. So it really calls for this urgent attention and HIV prevention efforts for these populations. So we know that PrEP is a highly effective intervention, particularly for gay and bisexual men, and shows promise for transgender women as well. But uptake and adherence has really been poor in many settings. This also comes at a time when there's kind of a shift in how youth socialize and network. They're not so much attending the venues that we're typically used to for recruitment. They're now socializing in online spaces and using a number of different forums, so Facebook, dating apps, Reddit, a number of fora to socialize. So there are two methods that we can think of now that are effective for reaching these populations. The first one that I'll talk about is respondent-driven sampling. This is essentially a chain referral sampling method that's been used to reach very hidden and diverse populations by building on peer networks and trust. For anyone who's not familiar with respondent-driven sampling, this typically begins with a small number of seeds. Usually we have about 5 to 6 seeds. In this case, I'll just show 1 seed. Seeds are typically well-networked individuals from the target population. We often know them because they're coming into community-based organizations or they're seeking the health services that are related to the health issues that we're interested in providing focus on. Those seeds might come into a study and participate. If they do, we ask them to invite a select number of their peers from the target population. And those peers, if they come in, if they're eligible and they participate in the study, they're in turn asked to recruit a select number of peers from that target population into the study. So as this progresses, we see more and more waves of people from that target population come into the study and hopefully participate in the study. Ideally, we would enroll about 10, 12, 15 waves of people per seed with that target population. One of the great innovations about RDS is that unlike snowball sampling, we keep it focused on a limited number of people who can be recruited. So here I have 3 people who could be recruited either by the seed or by the subsequent recruits. Sometimes that might be 4 or 5. But what's innovative about that is that it forces that recruitment deep into the population and hopefully away from the initial seeds and the first wave or two of participants who are recruited. So where we think about seeds as being people who might be highly engaged in services, as we recruit further and further into the population, we're hopefully reaching people who are less engaged in services. Another great thing about RDS that has made it so popular in the last 10 to 15 years is that we can use weighted estimation approaches to come up with something that can approximate a probability sample. So we can calculate population-based estimates. And so this has made RDS a very popular method for surveillance techniques in a number of settings. But I'll focus on the recruitment itself. So this is a diagram from our study in Moscow. This was a study with gay and bisexual men in Moscow City. And this particular seed, actually the seed is this top node at the very top corner. This particular seed recruited 31 waves of participants into the study and over about 1,300 gay and bisexual men into the study. And what we see here is this issue of the diversity in the sample that can be recruited. So the diagram itself is color-coded by HIV diagnosis at baseline. The pink represents those who had a negative diagnosis, and the blue represent those who had a positive diagnosis. And so as you can see, further and further we go in those waves, we see more and more men who are living with HIV at that baseline diagnosis. So we're hopefully reaching people who hadn't been diagnosed and now getting them tested and enrolled in care. So we can think about that as a way to reach populations who might also be eligible for PrEP or for other HIV care. So I'll take you to our first example from Project Parasol in Myanmar. This is a study, it actually focused on providing innovations along the HIV care continuum. So the way that we use this is we use RDS to recruit gay and bisexual men and transgender women into the study. They complete baseline HIV testing. And then, I should say, they're offered, if they had a negative test at their last HIV test, or if they have never been tested in their lifetime, they're randomized either to standard of care, which would be going to an MSM or transgender competent NGO clinic for HIV testing, or to receive HIV self-testing. Those who are diagnosed at that baseline visit then enroll into the HIV care cascade interventions, and they receive CD4 point of care testing and peer navigation. So while this isn't getting into PrEP, I think it highlights that it's a useful technique, and I'll show you here the RDS recruitment. So here you can see we recruited 577 gay and bisexual men and transgender women between November 2015 and July 2017. We saw a recruitment depth of about 4 to 12 waves per seed. The population itself reported a number of risk behaviors, so about 30% reported engaging in sex work, 30% reported condom use at their last anal sex across all partner types, and about 66% had never been tested for HIV in the past. We do see with the RDS recruitment that lifetime HIV testing was actually 75% less common in people who were recruited in much deeper waves, so about wave 6 and higher, compared to those initial seeds who were recruited. We also saw new diagnoses were slightly higher in later waves, but that wasn't statistically significant. Ultimately, we were able to enroll 79 participants into the HIV care AIMS, and we added another 63 through direct referral. But this was also a population that would have been eligible for PrEP. Unfortunately, as Dr. Tanya had mentioned, PrEP isn't available in Myanmar. There has been discussion within the government. There's potential that it will be offered for people who inject drugs in the near future, but not yet for gay and bisexual men and for transgender women. So we did ask about if people had ever heard about PrEP. As Dr. Tanya highlighted, there is a group of people online who are purchasing from across different countries, et cetera. In this case, actually only about 13% had ever heard about PrEP, and about 4% knew where they could obtain PrEP online. But once we described PrEP, and more specifically daily PrEP, there was high interest. So we saw about 95% of the sample were very interested in accessing PrEP, despite the potential drawbacks. They did voice concerns about cost, about the use of a daily pill, but they were still quite interested in it. And when we talked to the people who were living with HIV, they were equally interested, with about 98% expressing interest in having their partners take PrEP. So we'll shift back to the US and we'll talk very briefly about the PUSH study. This is led by Dr. Celentano and Dr. Sanders. And actually Renata will speak a little bit more in depth on this. But this is a study that's focused on providing PrEP to young gay and bisexual men and gender non-conforming youth in Baltimore City, Philadelphia, and Washington, D.C. It's focused on those who are aged 15 to 24 years. And we use RDS kind of in a similar method that we did in the Parasol study. So most participants are recruited either through RDS, whether they're originally clinic-based seeds or web-based seeds. They come in and they complete a baseline survey and HIV test. And instead of, as we did with the Parasol study, where we only focus on enrolling those who are living with HIV, this study has arms for both people who are HIV uninfected at baseline and living with HIV at baseline. So participants who are identified as living with HIV and who are virally unsuppressed moves into an arm where they're randomized to an enhanced case management versus standard of care for HIV care. And those who are not living with HIV are offered randomization into a standard PrEP referral arm versus the case management PrEP care arm. But I'll focus on the recruitment. So this is the RDS recruitment for PUSH. You can see it's a bit different from what we saw with the Parasol study. So these larger nodes, oops, excuse me. I'll just point to it. These larger nodes each represent a seed. And the shape of the node represents whether the person stayed in AIM 1 or moved into AIMs 2 or 3. So you can see some moved into various AIMs 2 and 3, the PrEP or the HIV care arm, or just stayed in that AIM 1, which is the RDS piece. What you'll note here that's different from the Parasol study is that we see a number of seeds who are recruiting people, but it only goes out about 1 or 2 waves in terms of recruitment depth. This, I should say, is not unique to the PUSH study. This is an issue that we're seeing emerging across the US in a number of studies with youth and adolescents. And here you can see this is just the enrollment diagram. So what's important to see is that as we're thinking about using RDS to enroll people into these various arms, the HIV care, the PrEP arm, it takes us about 10 screening and enrollments to enroll 1 person into the HIV care arm, keeping in mind that those are people who are virally unsuppressed, so they're a much smaller population. And it takes about 3 screening enrollments to enroll 1 person into the PrEP arm. So we conducted qualitative research to really understand what the issues are here. So the first thing that really came out in that qualitative research was an issue of small or underdeveloped networks. So as I mentioned, RDS relies on these very well-developed networks of these populations. But when you're thinking about youth, particularly those who are 15, 16, they might just be meeting people who are from that population. This study also focuses specifically on Black, gay, and bisexual men and gender non-conforming youth. So what we heard from some of the participants is, well, I know other LGBT populations, but none of them are Black. Or I know a lot of other Black people, but none of them are LGBT. So it was really an issue of, are we potentially cutting off those networks with the RDS? They also voiced concerns about willingness to refer peers into a study that's about HIV. So are they potentially going to disclose that they're living with HIV or that they're on PrEP by recruiting their peers? They also talked about challenges of immediacy. So we actually use electronic RDS in this method. We, rather than the typical paper coupons that we use and people have to hand them out to their peers, they just simply send a text message. It's about as fast as you can get. But even that is too slow for people. It takes time to look up their contacts in their address book. If their peer didn't respond immediately, they're probably never going to respond. So all of these challenges of immediacy, particularly for youth. And then finally, this aspect of non-random referral. So when we think about RDS, one of our inherent assumptions is that people randomly refer from their social networks. In this case, we actually heard from the youth that because RDS is incentivized, we offer a modest incentive to recruit their peers. What they were doing is they were actually seeking people who were very interested in health behavior. So they were interested in healthy living. They're probably not the people who might necessarily be eligible for PrEP, or they might not be virally unsuppressed. So they don't even necessarily meet our eligibility criteria for the study. So this led to a number of modifications. The first was to allow direct recruitment from clinics, but also to broaden the inclusion criteria, thinking that maybe we're being a little bit too strict in terms of the PrEP inclusion criteria and the risk behaviors required for that. Another really interesting innovation that we're just now starting is to allow female peers of young MSM and gender variant youth to enter as seeds into the study and help them bridge those networks. That's my ID. All right. Sorry, I'll just take this off quickly. Okay. So we can think about other options like online recruitment. And this is an area that's exploding in use right now. And you'll see a number of different studies publishing on online cohorts or online surveys, et cetera. This really builds on the widespread internet access and the use of dating apps among youth and among adults as well. And typically, it actually comes in a variety of flavors. So typically it uses electronic marketing of study or program materials through either dating apps, social media, advertisements on popular sites, et cetera. And you can see these in the way they appear as banner ads. Typically, they might be full-page interstitials, or they might be sort of sidebar images that you see on a website. There are also more direct methods. So some people might use direct communication within Facebook or other social media sites where they're directly communicating with participants from a profile. Some people might collaborate with social influencers to have them posted on their profiles or their Twitter feeds, et cetera. And there's now emerging access to search term-based advertisements. So specifically, Google Ads is one of these, where you can identify a number of search terms that people from your target population might be interested in and try to target ads based on their search history. And the great thing about these methods is that if you're electing to advertise on Google or Facebook, et cetera, you're not advertising across the US or across the world. You can geo-target your ads to whatever site you're interested in. In some cases, you might be able to target ads to specific individuals based on their profiles or based on their search terms. So one of the beautiful things about this emerging internet access and these apps and social media is that it has been a source of community-empowered prevention. So I'll show you a couple of diagrams. The far image here is from a dating app. And you can see here, it's actually a little bit hard to read because of the colors. But this person actually, this is a dating app profile from one individual. You can see actually Emory has their banner ad across the bottom here. But here, the last comment in this person's paragraph says that they're HIV negative and on PrEP. So people are willingly reporting their status and whether or not they're using PrEP. And so it's really a community-empowered prevention technique. There are Facebook groups. So this is an image of a PrEP Facebook group that has 20.9 thousand users from across the world that share information about how you can buy PrEP if it's not available in your country. You can see they just recently posted results from CROI. And then this is a subreddit that's for transgender individuals. And they posted results from AIDS 2018 about the potential interactions between exogenous hormones and PrEP. So the LIGHT study is one study that we use online recruitment methods. We actually use a variety of recruitment methods. This study is a multi-site study it's a cohort of HIV uninfected transgender women. And it spans 6 cities in the US and eastern and southern US. And we've recently actually expanded it to include about 20 cities, focusing specifically on an online cohort for those other 20 cities. So we initially started off using dating apps, but the challenge with dating apps for transgender women is there actually isn't a dating app for transgender women. So they're on Tinder, a few of them. There might be a few on Grindr, but that's generally about it. So those didn't pan out so well for us. So we switched to Google Ads and subreddit. So Google Ads, we basically said, okay, we want to find people based on their searches for transgender information about transgender people, transgender women, et cetera. So we gave about 3 search terms. And Google Ads has basically a learning algorithm where once people start to be identified by clicking on those search terms and seeing your ad and clicking on the website, it starts to learn their search terms that those individuals have used after they've clicked on your website. And so here you can see all of these other search terms have evolved from that learning algorithm, and now we can start to identify people and recruit them. And basically, if you've ever used Google, I think everyone here has probably used Google, you get that initial page of results for whatever your search term is, and typically you'll see there's something that comes up, it's marked with an ad. It says very obviously that it's an ad, and it just has a little bit of information as well about the study. So people might click on that because they see that there's a study they're interested in. So here you can see we report our click-through rate. So the click-through rate is the number of impressions, so either full-page interstitials or banner ads. In this case, it's that ad that have to show before someone clicks on it. So in our case, 0.9% of the interstitials that are shown are actually clicked on and hit on our website. That seems very low. It feels low as someone who pays for it. But it's actually relatively standard in online recruitment and advertising. You can imagine if you think about all of the ads that you see on the sides of your web pages when you're browsing, how many do you actually click on? Same thing here with the subreddit ads. So these are a number of different subreddits that are focused on the transgender population, some specifically trans women, some broader transgender, gender nonconforming. And again, we have a click-through rate of about 0.3% with a cost per click of about $1.30. So those clicks actually don't always necessarily materialize into people who participate in your study, of course. So actually your enrollment rate is much lower than that. And this is what it looks like from our website analytics. So you can see we had a number of people hitting our website from the dating apps, but it didn't really translate into enrollments. And then here as well, you can see now introduction of our Reddit and Google ads. It's about 500 people a day, keeping in mind that this is only in 6 cities. And then as we expanded to 20 cities, we go to about 1,000 hits per day on our study website. But we ultimately are enrolling people. So in Baltimore and the other 6 cities, we have about 650 people who are enrolled in the cohort. They're a population who are eligible for PrEP. So this is the results that are stratified by adults and youth. We enroll as low as 18 years, so this is 18 to 24 compared to those 25 and older. And so among those people who are sexually active and who are HIV uninfected, we see about 90% have heard of PrEP. They're aware of it. But then only about a quarter have actually ever taken PrEP. Even fewer have been on PrEP in the last 30 days. And then about 12 to 14% are adherent based on the use of 7 pills in the last 7 days. And that's, I should say, this is focused on our traditional cohort. It's the facility-based cohort, it's not our online cohort. So then we can look at how people actually are recruited in Baltimore and the other cities. And so in Baltimore, this is stratified by Baltimore compared to the other 5 sites, we see that plain old referral friend with a friend has been the most effective way for us to reach people in Baltimore City, a little bit less so in the other sites. Some people are recruited by healthcare organizations. That's particularly a product of the other sites we work with, Fenway, Kaylin Lord, Whitman Walker, where a lot of the people come in from those clinics. And then a variety of other ways in which people have been reached. But our Facebook ads, other websites, study websites, they really have much lower payoffs than we would hope. That said, in our online cohort, we just launched that in January, we've had 296 people enroll online through our online recruitment methods. So what we see, and that's in basically a matter of 1.5 months. So we see that the people who are online, they're happy to participate in things online. And when it comes to facility-based engagement and engagement in PrEP potentially, unless we can think of more electronic methods to engage people in PrEP, it's much more challenging to use these online methods. There is one study that has effectively reached people through online methods, and that's the COPE study. Chris is going to talk in much more detail about this. This is an open label combination prevention effectiveness for cisgender men who have sex with men and transgender women who are engaged in sex work in Bangkok and Pattaya. We've developed a number of PR tools for use online, so again, through Facebook, websites, other social media. Line is a very popular kind of WhatsApp version that's popular in Southeast Asia. So we post online. These are kind of various discussion forums. And we've made a couple of very high quality professional PrEP videos that really encourage PrEP use. This is a video with a transgender model. We have another one with this model from Apollo Male Massage and his partner. And they're very engaging videos and exciting. And that's really brought in a lot of attention about the study. So to date, we've enrolled 445 participants in that study, and that's given us so far about 168 person years of time on the study. About 74% of participants have actually initiated PrEP at the baseline visit, and then many more have initiated in subsequent study visits, giving us about 134 years of person time of adherence on that on PrEP in that study. So very engaged, very interested participants who are coming into the study facilities in Thailand. So I'll pause there and just say, in closure, there's not one perfect method for reaching and recruiting youth and young adults in these particular settings. And if the goal is really to reach people and get a large number on PrEP and other programs, combination approaches are probably the most ideal, where you can reach the broadest segments of those populations. We need to think about, when we're using how we're using RDS, how to engage subgroups without cutting off those networks, those network structures that underlie the populations. Dating apps have been very popular recently in terms of research and programming. They're a great way to reach gay and bisexual men, but it's important to remember that they're restricted typically to people who are 18 years and older, and they're not so effective for reaching transgender women. And then online approaches can often reach a very large number of people very quickly, but they've been less effective in recruiting people into facility-based programs and research. So I'll stop there. Thank you for your attention today. Thank you for inviting me to speak.
All right, great. Thank you, Andrea. We have time for a few questions. Maria Trent in the back.
There's data that suggests that there's a fall off in PrEP use with the CDC, particularly amongst younger populations. And I'm wondering how you see social media as transforming how people think about it and think about adherence. It's one thing to sort of get people in, it's another thing to help them maintain. Do you have thoughts about that?
Yeah, well, a couple. So in terms of social media, I think back to that page where I showed you the Facebook groups that are really focused on PrEP. It's been a very kind of organic, community-empowered approach to sharing information about PrEP. And I think that that's probably the way to go in thinking about how we can encourage people to kind of organically take that on and share positive messaging about PrEP use and retention on PrEP. Aside from social media, there have been a number of other intervention approaches, not necessarily to using social media, but to using similar apps that allow people to form groups, to support each other, and to kind of find ways to maintain adherence over time. And so we're seeing about how those are turning out in terms of their effectiveness. Go ahead.
I guess my follow-up question. I was recently at the STD meeting in New Zealand, and a person said that people would never use condoms again.
Hold one second. Maria, they can't hear you because it's online. I'll have you repeat into the mic.
I was recently at the STD meeting in New Zealand, and one of the speakers said that, as an example, gay men would never use condoms again. We should just not go down that path again because we have PrEP available. And it was an interesting notion, and it's almost political. And I guess for me, I'm wondering, could that kind of movement, particularly in places like Baltimore, I sort of haven't seen it that way, like it's your right to be at zero. Have you thought about that?
Yeah, I think that's an argument that we hear universally. I think Dr. Tanya, we kind of gave a really nice example of how people might oscillate between PrEP use and condom use. I think that's an area that we actually really need to learn a lot more about. You know, one of the challenges with our analyses of PrEP use is that we're focusing on people who are not using condoms, right? And so it's also kind of like a chicken and egg scenario of this argument that people aren't using condoms necessarily. We need to think very clearly about our analyses around that. But I think this is where the area is now, is how we're sort of understanding whether people are protected in some fashion, whether or not it's condoms or PrEP or both.
I would just add that it's not just only a PrEP issue, right? It's also the whole movement around U equals U, right? And undetectable is untransmissible, and so that is having a big impact on condom use. And also that, sex workers are a subset and are kind of a different population. And the men in this study that Andrea mentioned that I'll talk about next or all have a history of recent selling sex. And there, the condom use is still staying up around 70%, which is, quite remarkable. But sex workers are different.
Tanui, you had a comment?
I have two questions about the recruitment strategies. So when you talk about seed to like enroll more people, and have experience use that for adolescent, and also how it's affect on when you ask for IRB ethics committee, because it seems like adolescent themselves will be like, it seems like a staff members who enroll peers, and how you construct that when you have IRB ethics committee review. And the second one is on internet-based recruitment. I think it's quite new to ethics committee in Thailand. We also start to think about how to use that platform, and what the extent that strategy has to be approved or reviewed, because you get access to quite personal information when you use the learning algorithm, try to target them.
So for RDS, that has been used among adolescents. So the PUSH study is one example. That was 15 and over. It was approved by the IRB. I think there's always, specifically for youth and for gay and bisexual youth and transgender youth, there's a lot of attention from the IRB on, are you protecting them? Are you keeping their information private, et cetera? And so that has been an area where we've continued to work for a number of years, both with our adult studies and now recently with PUSH. I think it does take a lot of thought in terms of thinking through the messaging that's shared, the electronic coupons. In other studies, as I mentioned, we use paper coupons. They never state anything about it being an HIV research study, for example, or it never states sometimes the location of the facility in certain settings where homosexuality is criminalized. So there's a lot of considerations around that, and I think the scientific community has done a very good job of continuing to work and build on those protection practices and build them into the human subjects protections. From the online recruitment process aspect, there is, again, that's also an emerging area for IRBs. With Google Ads, we don't access that information. It's a algorithm that runs in the background in Google, and so we don't access anything about what people are searching, et cetera. We just see what are the kind of common search terms that people use who hit our website, and that's as much as we know. And so it does take a lot of understanding of the online and sort of the IT pieces to be able to report that and be very clear about that to the IRB, and make sure that people's personal information isn't collected. We don't collect IP addresses, for example. We don't collect any GPS data in those online methods. And so from a researcher perspective, it is a huge learning process, a huge learning curve to understand all of these different ways that you can recruit online, and then also understand the ways that it could potentially harm people, and making sure that you're then not harming people, right? And it's also challenging because this is a space that's evolving very quickly. So for the good and for the bad, right? So there are new methods that you can reach people, but now there's also, for example, new government restrictions that change within a day how you can reach people online. And that's a good thing, but it's also like you suddenly have to learn how to adapt and be able to recruit people too, and figure out what that means for your particular study.
So there's a question over there, but while she goes over there, I actually have a couple quick questions. So one, I was fascinated by the Moscow data with all the waves for RDS. Mm-hmm. I'm curious if you drill down into the young people, and were they as wavy as the overall cohort? That was one. And then two, I was recently at the Society of Adolescent Health and Medicine, and there was a panel discussion where a youth said, we don't need you researchers in our Jacked and Grindr. We're there for a reason, and we don't want you there. It's gotten super crowded. I'm curious to hear if you've heard some of that feedback from young people. Like, get off our Jacked and Grindr space. Let us do what we want to do, and just how to reach them differently.
Yeah, so in terms of the Moscow study, we didn't see any differences so that was again 18 and over, and we didn't see any differences by the younger adult population versus the older. That was very successful in Moscow, and I think that was again because of the changing climate in Moscow. So during the study, they passed the the law that banned the sharing of information about homosexuality. And so people were actually going from a setting where they could be in venues to where they were actually kind of networking more underground and more private spaces. And so RDS actually worked really well in that particular setting. And then to the question about Jack'd and Grindr, we haven't quite heard that so much. We really did a lot of the qualitative research with transgender women, and again, because they're not on that so frequently, they didn't seem to really have a problem with that. I will say that there is interesting feedback from Grindr specifically, and their sort of caution about engaging research in their apps. So there have been studies that have shown that Grindr users have relatively low condom use, and that has resulted in some researchers who can't use Grindr anymore for recruitment methods. So I think it's actually a space of how we can work with these dating apps where research is not necessarily their interest, but they do want to show that they have a healthy population and that they're partnering with us. But there is tension there, actually. Yeah.
So one last question over there.
Hi. So this recruitment approaches and strategies are really fun and interesting and creative, and I was really excited to see those. I was wondering if you could talk a little bit. You said there were 296 folks that were recruited online in the past 1.5 months. And is this an online only survey, or do they have to, is it facility based at all?
No, so the LIGHT study itself, it started out as a kind of a hybrid facility-based and technology-enhanced cohort. So we require that people, for what we call the traditional cohort, we require them to come in for the baseline study visit and then the 12 and 24-month study visits. Mm-hmm. We have study visits every 3 months, and so we've developed an app, so I had an image of our app. They can complete their app and their HIV self-testing at home and completely use our study app to provide those survey data and to report their HIV test results. When we expanded to the online cohort, that's completely online. So again, they can use the app, they can use a website to complete the surveys. And we provide them with oral specimen collection kits that they send to Quest Lab, where they can do the HIV testing and confirmatory testing.
Okay, so the baseline visit, they have to come in to be enrolled.
For the traditional cohort, yes, but for the online cohort, no.
Okay, so my question has to do about screening and enrolling someone online, and what strategies are you using so that folks aren't misrepresenting themselves mm-hmm. or sort of dodging, certain questions in order to get enrolled?
Yeah, it's challenging, actually. A lot of researchers will use things like they'll only allow one person from one IP address to participate in the study. We don't have that requirement on ours because of the fact that technology access is quite various. And some people might be sharing computers, they might be at libraries, they might be at community-based organizations. We do collect phone numbers and we do collect the city where they live so that we try to match those. If someone enters and tries to enroll with a duplicate phone number, they're not allowed. We also kind of do a screening of the data to make sure that they do look like they're valid participants and they're answering the study survey questions. But it is challenging. I mean, even some people will screen out VoIP phone numbers, for example. So those are things like Google Phone. But again, with our participants, there are a number of people who use those as well. So we can't screen those out. But it is challenging. We've tried to come up with kind of the best set of screening questions and then survey questions to be able to do that. And then for complete enrollment into the cohort, they have to provide an oral HIV test as well.
Okay, so high barriers.
Mm-hmm. Yeah.
Please give Andrea another hand, please.
Thank you.
Okay, the next speaker needs no introduction, but I'll give him a brief one anyway. It's Chris Byer, who's our Desmond Tutu Professor in Public Health and Human Rights, and Associate Director of the GHU CFAR, and a mentor to our ISWAG. His title of his talk is Cope for YMSM, High PrEP Adherence and Persistence Among Young MSM Who Sell Sex in Bangkok, Thailand. Thanks, Chris.
Thanks very much. Delighted to be here. What a wonderful morning, and so nice to have you with us, Dr. Tanyui, really. And I see Craig is in the back, who was your academic advisor for the time that you were here. So good to see him. So this is the basically preliminary data. We're about a third of the way through enrolling in this study. But I thought it was worth sharing where we are and some of the findings. The study is called the COPE4Y-MSM, and COPE is basically for comprehensive preventive intervention. And what we've been finding is something that we think is really pretty exciting, which is that this is a population that has had high interest in PrEP, high adherence, and unusually quite high persistence on PrEP. So many of us just came from CROI, and persistence, which is the longer term staying on PrEP and staying adherent to PrEP as prescribed, is turning out to be a very big issue with this intervention. But we'll talk a little bit about why these guys seem to be doing better. So this is an effectiveness and cost effectiveness intervention. It is an open label assessment of a comprehensive prevention package that includes PrEP or not. People can start and stop PrEP when they want. And we are looking also at the use of adherence supports, particularly an SMS messaging system I'll talk about a little bit. And it's for young men who have sex with men and transgender women, so it's 18 to 26-year-olds who sell sex in Bangkok and Pattaya. And for those of you who don't know, Thailand has quite a large commercial sex industry, and among men, so for gay and bisexual men, it's the largest commercial sex industry in the world. So that is why we thought this was a very appropriate place to look at PrEP. And the idea here really is occupational PrEP, PrEP for people who have risks associated with sex work. We did, in fact, want to go a little bit younger. We've talked about this quite a bit, but as far as the WHO is concerned, and the Thai government follows this as well, you can't really be a 16 or 17-year-old sex worker. If you are under age 18 and selling sex, you're defined as a sexually exploited minor. And so it's a very different dynamic. And so while sex work is illegal in Thailand, it is tolerated for adults. So everybody here is 18 or older. Basically, two objectives: to assess the effectiveness of an open label combination preventive intervention with or without daily oral Truvada, and then to assess the cost effectiveness of that, looking basically at number of infections averted through PrEP use, discontinued treatment costs saved, and dailies averted. Brian Weir, who was a postdoc on RT32 and now is faculty here at the school, is leading the cost effectiveness component of this with our CDC colleagues. It's, I think, an innovative study design. We, of course, developed this design after several efficacy trials had established the efficacy of daily oral PrEP for these populations. And so, how do you look at effectiveness for something that we already know works? And the idea was that we would take a person-time approach. We would allow people to start PrEP when they wanted, to stop when they wanted, so people can add to both person time on PrEP and person time off PrEP. And there is no prospective assignment. So this was deemed by the NIH to be not a clinical trial. Under some of the new, more strict definitions, this is it's a battle that we seem to fight every few months with DAIDS. But at least for when it was funded, it was definitely deemed not a clinical trial. The idea at the beginning was that we would follow people for a year, but last October, we started to have the first group of men who had, and trans women who had finished 12 months on PrEP, and many of them wanted to continue. And the data are very clear that one of the highest risk periods for HIV seroconversion is post-cessation of PrEP. So actually, our protocol had no exclusion based on having previously been on PrEP. So we basically allowed people to finish the study and then re-enroll, and now we're going through the whole IRB amendment to allow this to be 24 months of time and really look at persistence more longitudinally. So the inclusions are assigned male sex at birth, Thai citizenship. This is something we're actually very unhappy about. The Thai National IRB insisted that this intervention only include people who could prove Thai citizenship. In fact, about 2/3 of the men in this industry are not Thai. Many of them are Burmese, Cambodian, So we know that we actually are excluding some of the most at-risk men. But when you operate in somebody else's country as a collaborating investigator, it is not your call. And the argument, by the way, if you're interested, was an argument on bioethics. They essentially said, if somebody is not a Thai citizen and enrolls in your study and is not adherent and becomes infected, we can't guarantee that they will have access to antiviral therapy. Therefore, it's not ethical to enroll them. So, yeah, I know. And then our definition of sex work is very broad. So basically, you have to report having sold or traded or exchanged sex at least once in the last 12 months with another man. So that's a very broad definition. And obviously, we have a number of sort of standard exclusion criteria. 4 sites, the Pattaya site has not been opened as yet, and our partners are really, very importantly, the community-based organizations that are, that are serving this community. So we are working in a community clinic that's run by the CDC, the Silom Community Clinic, a Rainbow Sky Association of Thailand, which is an LGBT organization that now is a PrEP provider. And then with Swing, Swing is the Sex Workers and Network Group. It's the sex worker union. It's a rather unusual union, and that includes men, women, and transgender sex workers. And they have a clinic in the red light district in Bangkok, and they have one in Pattaya. So we're also enrolling in Bangkok in their clinic, and then beginning to enroll in Pattaya, hopefully this month. And this is, Dr. Tanyui will know, an example of what the Thais call key populations-led prevention services. So these are clinics by and for gay and bi and trans folk and sex workers. The sex worker clinics, all the counselors are either active or former sex workers, and people are really providing PrEP for their own community, and we're helping make that possible. So if folks can enroll and choose not to be on PrEP, and then that's the study schedule, and we're following them prospectively, or they can join PrEP basically at any time up till the 9th month of the study, and then start taking it, and there's a lot of variation of when people stop and start. Most of the people either start at the first visit, they're coming in because they want PrEP, or within about 3 months, typically. So we do a lot of standard procedures. We do HIV diagnostics. We exclude acute infection. We do regular screening for kidney function with creatinine. And I'll show you, we have a very nice new technology that the CDC assessed for this study, and that's now being widely used, which is a handheld creatinine reader that can be used in these community clinics. This is what it looks like. You can see that's actually a hand there. It's sort of about the size of a cell phone, and you get a creatinine read in 20 seconds. So that allows us to do same-day PrEP initiation. I know, isn't that exciting? Yeah. It is, very exciting, yeah. Technological innovation. And these point-of-care diagnostics, of course, are changing lots of fields in medicine, as we know. So just to say where we are, we have an overall goal of eventually reaching about 1,200 person years on and off PrEP. We have screened and enrolled, actually Andrea's data were a little more current, about 450 men or so. Started close to 330 on PrEP. We also have a number of people who've re-enrolled. That's getting up to about 50 now. So their actual numbers on PrEP are more person time basically accruing, although fewer people, but with a person time approach that actually works very well. I just wanted to say what we're looking at in terms of retention. So this is, you have to say, only in Thailand could you report that after 1 year we have had 1 loss to follow-up. Is that incredible? And yeah, I mean, people are, this is where we are up through 12 months. We have 95.6% retention at a year. This is the Rainbow Sky Clinic. They just started more recently, but they're also basically able to follow about 100% of men. So really quite extraordinary retention. This is what the person years look like. Andrea showed you this, but so the total Person time is up on top. And then we use an SMS reminder system. People can choose a daily or weekly reminder, and they get a weekly questionnaire on their phone. How many doses did you take in the last week, for those men who are on PrEP? So anybody who reports 4 or more, we consider adherent for that week. And we're using a weekly measure of adherence. And that's, for those of you who don't know, because biologically, basically, there isn't really any difference in protection for men, not true for women, but for men, whether you take 4 doses a week, 5, 6, or 7. So this is fully adherent. And that is really quite extraordinary. Now we're gonna have to validate that with, we have dried blood spots from every visit, so we're gonna do DBS and validate that. But at least for now, it really looks quite extraordinary. Non-adherence is very rare, or let's say self-reported non-adherence. This is the proportion of men who are not on PrEP. But here's the thing. This is all happening concurrently with the Bangkok Men's Cohort Study, which is an ongoing cohort study. So that cohort is in the same clinic, and this is our referral base for men coming into this study. So we have actually an observational cohort ongoing that is essentially in parallel. So the incidence in that observational cohort is about 4 per 100 person years, which has kind of been the standard rate in Thailand for MSM, unfortunately, for many years. But the subset of men who sell sex, so for sex workers in that cohort, it's 11 per 100 person years. So among these folks, we should, with 168 person years on PrEP, with this self-reported adherence, you know, the number's pretty impressive. These are 33 person years of people who are not on PrEP. We should have some HIV seroconversions. And how many have we had with this very high-risk group of people? None. So that is the best measure of adherence that there is, right? And the comparator, of course, is the guys who are being followed observationally, where they're still seeing, unfortunately, extremely high rates of infection. So just to say, we were recruiting relatively slowly. I'll show you the recruitment numbers. We actually had planned to do this social media online recruitment with those videos. I will just say this is the first study I've ever done, which is an NIH R01, which funds the CDC Foundation, because our partners are at the CDC. Don't do that at home. You know what I mean? Don't try it. It is so incredibly difficult. And of course, we had to get a waiver to include all these community groups because, as all of you know who are NIH investigators, you're not allowed to do a sub on a sub, and that is what we are doing. This is an NIH grant to Hopkins that then subs to the CDC Foundation and then to the community groups. So it is not easy, and it takes a lot of work, and getting this contract out the door to start the online recruitment took almost a year. And the Thai IRB was incredibly conservative also about that very, very long delay to get that going. But eventually, we were able to launch it. And I just want you to pay attention to this one area, which is social influencers. So we hired a group called APCOM, the Asia Pacific Community of MSM Organizations. They're a regional organization, Bangkok-based, that does outreach and education for gay men. A very engaged and very technologically savvy group. They developed the videos for us, and then they developed this online campaign. And then what we had to really pay for was the use of these social influencers. So social influencers are basically people who, from that community, have a big online presence and can bump your content. And you pay them, and they push out their content, push out your content. So these social influencers that we hired together had about 5 million followers on social media. And that is literally what you're paying for. How many people follow them on Twitter, how many people follow them on Facebook, and so forth. That got us almost 40,000 views of our videos, which is really what you want, is eyes on your content. Reactions are when people, actually click, then go onto the website, or like the video, or share the video, or put a little emoji on the video, some comments, some shares. That summarizes the total engagement. But let me show you, and this is what the materials look like. I think I have let me show you the way the recruitment was working. So we were doing okay, we were moving along, and September of last year is when we finally were able to launch this video content and the social influencers. You can see what the total recruitment is looking like. We did the first wave in August and then September, and then we really doubled our recruitment. So you get what you pay for, as it turns out, with social influencers, and it really does make a difference. I just presented this to the DAIDS folks when we were at Croy, and they just kind of let out this big sigh of relief because this is precisely the direction that you really want to see things go in. The good news is that, you know, when you do this kind of social media campaign, there's always a concern that you're going to get more attention, you're going to get more clicks, you're not necessarily going to get the kind of people you want actually coming into the clinic. Are they uninfected MSM and trans women who actually are sex workers? The wonderful thing about this and this takeoff is that we had a substantial increase in people who really met our study criteria and were coming for PrEP. So that really told us that, you know, the content that we're pushing out there is meaningful to the population. Let me just back up and I'll show you this. What I mean by that is, for example, these are the videos that you're looking at, stills from the video. Apollo male massage does not exist. David is on. There is no Apollo male massage, but there are about 30 of these gay massage parlors in Bangkok and Pattaya. They have large numbers of employees. We made up, this is a fake name, but this is the idea. Everything is branded with that. So if you are a sex worker and you are working in one of these massage parlors, this says to you, this is for you, right? And for others, it can be sort of off-putting. Why would I want to be involved in that, right? I'm not a sex worker. The one with the transgender woman star actually had a vignette. The scenario was her engaging with a boyfriend and then engaging with a sugar daddy, with an older man who's taking care of her, and then he is encouraging her to remember, don't forget to take your PrEP. You know, it's a kind of so it's a different kind of sex work from Apollo. Just click through this quickly. Isn't that exciting? I know. We're nerds. What can we tell you? You know, this is this is the same data, but just to say, this is when we added the Rainbow Sky Clinic. This is when we added our sex worker clinic. This is when we really started hitting the social media. So what are we doing next? Well, we're going to now propose a new study. We had planned to use the dried blood spots really just on seroconverters. It's not such a cheap assay. But now that what we're really looking at is a population with high adherence and high persistence and high self-report and not self-reported adherence and not HIV seroconversion, we're really going to have to validate that with the dried blood spots. And I just wanted to add this point, Carlton, this is to your question. These are the social harms that we have had in the study. These are the 7 ones that we had to report to the IRBs. Is it me? Am I near a cell phone?
It's your collar.
Oh, it's my collar. That's annoying. I don't think it's my collar. I don't know what that is. Okay. Sorry. Okay. Is that okay? Can people hear me? So, you know, they're very consistent themes here. So people are asked, somebody saw the Truvada and then said, you know, are you living with HIV? A partner, a casual partner, the same thing. One was a colleague at work. Somebody saw Truvada in their bag. This was a transgender woman, reported it to a manager. I don't want to work with somebody who has HIV. Another was actually a client, questioning about a client. And then this last one was somebody who a client took to Indonesia and was stopped at the border, and the Indonesian border officials looked at the drug, Googled it, and said, well, this is an HIV drug. We don't allow HIV-infected people into our country. So, these are all HIV stigma related and not at all related to either being a sex worker or being an MSM or transgender woman. So I think that really speaks to the persistence of HIV stigma, unfortunately. So we feel that this is going well. These are our partner sites. They're all activated. We have one more. The AppCom publicity campaign online really made a difference. And I just want to end there by thanking all the people who are part of this study. Andrea Woods, as always, been invaluable partner in doing this research. And here at Hopkins, Brian Weir is doing the cost effectiveness. Michelle Decker helped us with the community mobilization. Steph was very involved in the initial design, and the study is coordinated by Sandra Maughan. And then we have a whole number of colleagues at the Thai US collaboration at Mahidol University, Patrick Sullivan at Emory's, our consultant. There's a statistical group at the CDC. We have these wonderful community partners, and of course, we have amazing participants. There's David and I have been doing work in Thailand for coming on 3 decades. It is just incredible that you get these levels of adherence, retention, engagement, one person lost to follow up among a population of sex workers. It's a country that continues to be just a wonderful place to try and answer important public health questions together. So thanks very much. Do we have time for questions?
I think we have time for a few questions because we have some, Dr. Trent in the back.
I love this concept of public outreach. Could you share with me, would you be willing to share with us how much money you invested in the videos and things? I found that sometimes the public health videos are not the same quality as some of the commercial marketing videos around sexual health, and I was wondering if you could share.
Yeah, the videos, Andrew, maybe you remember precisely how much each one cost. The overall contract for all of it, pushing it out, cost about $25,000 US. And I think the videos cost around sort of between 6,000 and 8,000 US each. The made in Thailand, yeah, absolutely, and of course they're all in Thai language. They actually were a sub of a sub of a sub. AppCom hired a group called Trasher, which is a video production company there, and they used actors, trained people, but it turns out you post these things, you get what you get, but the social influencers really drove the content in the right direction, and that turned out to be, and we had to pay for that as well. It was a couple of $1,000s, but it was worth every penny, clearly.
I actually had a question about the social influencers. I mean, people have heard me joke around and say we should get Beyonce, but now Cardi B to be a social influencer pushing for PrEP or something. How did you find those individuals? They look cool and et cetera, but were they actually social influencers or just actors that you created and made them be social influencers?
Yeah, no, we very much relied on the AppCom, which is is an LGBT organization. They know who these folks are, and the social influencers. I mean, they have to be able to demonstrate how many people follow them. And they're in this case very specifically people who are known and followed by young gay people. So that's the group that you're after. So and if you were, for example, trying to do better with minority MSM, it would have to be people who could demonstrate that that's their following. Yeah.
Chris. Oh. The risk compensation, I'm sure you're going to look into, but are there any difference in terms of unprotected sex among those who are on PrEP and those who are not?
So you have to think about what you mean by unprotected. Right? Sex on PrEP, adherent, is not unprotected sex, right? Yeah. Well, condoms are great. PrEP is better than condoms if you take it as prescribed, substantially, right? So that's an important distinction, right? What people propose for STI prevention is that you should use PrEP and condoms, right? So, it's been true for male and female and trans sex workers in many studies for many years that they tend to report higher and more regular condom use with commercial partners than other people. And they report the same condom use with romantic and primary partners as other people, which is always bad, right? I mean, that's life. What we define now and are working on measuring when we talk about unprotected sex for these folks is fewer than 4 Truvada doses a week and not using a condom. That's what unprotected is, right? More than 4 doses a week or condom use or both is protected. Great. Oh, sorry. Go ahead.
Have you thought about what's the acceptability in terms of availability of PrEP after the study ends? What's the context?
So you heard, as Dr. Tanwi was saying, that the Thai government has been debating whether or not to include PrEP in their national health scheme. That debate has been going on, in my view, too long. Right? They keep hemming and hawing and making decisions. One of the reasons, or delaying the decision, I should say, one of the reasons why we're focusing on cost effectiveness in this study is because the ministry said, okay, we see the data on efficacy. We want to know whether this will be cost effective in Thailand. So this actually has a policy basis, and we're hopeful that it's going to make a difference. I think what we're seeing, and there's of course a lot of studies out there about the cost effectiveness of PrEP, is that it's cost effective if you're reaching people who are really at substantial risk. It does not look terribly cost effective if, for example, you say, okay, we're going to give it to adolescent girls, which a number of countries are attempting to do, very large populations with very heterogeneous risks. So this group, where we have evidence that the seroincidence is 11 per 100 person years, we think is going to look highly cost effective. And we've had to change the plan for the cost effectiveness analysis such that we're using basically the 18 to 26-year-old MSM who sell sex in the Siloam clinic as the comparator. I don't know if that's helpful to you, but what we hope is, of course, that eventually they will make a decision to make PrEP available. The other thing I should say is that they manufacture Truvada. They manufacture a generic 2-drug component. It's tenofovir emtricitabine. They call it Tino-EM, and it's very cheap. And it's used basically as the backbone of their treatment program. And they export it to many countries. A lot of the Truvada that's used in the UK, for example, is Thai manufactured. So if they do make that decision, it will not cost anywhere near what it costs here. Great.
I just wanted to follow up on a comment you made about the 4 doses a week or more being protective, and I think generally that's
for men.
For men, agreed. And I just wanted to add a modest note of caution to that for transgender women.
Yeah.
There's now 2 studies, and importantly, the best study is the Thai Red Cross HIVNAC group that showed about a 15 to 18% reduction. We've showed about a 25% reduction in blood levels. Yeah. And colon tissue levels are only about half, although it wasn't statistically significant, which may have. So in terms of an adherence measure, they're following the rules, so that's terrific. It doesn't affect your data at all, but
it will.
Safety. It will be interesting to see if the numbers are sufficient, because I imagine you probably have a larger transgender proportion in your population than probably anywhere else. So it'll be interesting to see how that plays out. It's just, if there's any providers of, PrEP to transgender women, I think there's reason to caution that the 7-dose-a-week regimen for women applies to trans women as well. I think, at least until we have more definitive data to prove that that's not necessary. But I think it's prudent to be more conservative in terms of what's recommended.
Yeah, yeah. So everybody here is being recommended daily oral, and actually, interestingly, in terms of the choices, the great majority of people have chosen to get daily reminders, which costs us a lot more money. But nevertheless, that's what people wanted. Just to say, the fourth site that we're opening, which is in Pattaya has a much larger proportion of the commercial sex scene as transgender women. So we expect that we will be substantially increasing the enrollment there. And it's absolutely the case that what I showed you in terms of person years is a blended outcome right now. We would love to be able to disaggregate that if we have the numbers. But yeah, well taken.
I'm going to take one more question and move to the last speaker.
Please.
Thank you. Good morning. So I was going through I'm doing a literature review on PrEP, and I was going through some papers, and there's been this report that younger MSMs tend to over-report their adherence. That's when you use self-report. So I just want to find out if, when you compare the self-adherence on PrEP and then you confirmed with the biological tests, was there like a correlation or a major difference between?
So we haven't done that analysis yet. That analysis is pending, and we actually don't right now have that analysis funded, because what we were going to do was use the tenofovir diphosphate, the intracellular assay, for seroconverters, and since we're not seeing seroconverters, we're going to have to really look at adherent and non-adherent men. So that's a stay tuned. We'll have to see how that goes. These are all young men. Depends on how you define young, but they're 18 to 26-year-olds. So this is very deliberately to look at young. We may be able to divide something like 18, 19, 20, or do a cutoff at 22 or something like that. I will say that in retrospect, when we've looked at the enrollment issue and the uptake, the single most common reason for not being eligible for our study is being older than 26. There's a substantial number of sex workers who are up to sort of early 30s. So probably for the next time around, we'll go with higher age, and then that will be a more clear analysis, I think.
Great. Another hand for Chris. He never disappoints. All right, our last speaker, but not our last part of our presentation, is Dr. Renata Arrington-Sanders. Renata is Associate Professor of Adolescent Medicine in Johns Hopkins. She's also one of the co-directors of the ASWAG. Her talk today is entitled PrEP, Strategies to Engage YMSM and Transgender Women Living in Baltimore, DC, and Philadelphia. Renata.
Thank you, Allison. I think I've been told to stand here in order to avoid feedback and not to use the microphone. Okay, so I'm actually going to focus really on adolescents and young adults and present one strategy that we've been using here in Baltimore, DC, and Philadelphia, and what we've learned, as well as hear from you. I think it builds on what you've heard already this morning. So as you all know, HIV disproportionately affects individuals worldwide, particularly adolescents that are 15 to 24 years old, as shown here. And there are key populations that you've already heard about, particularly in the United States. Young Black men who have sex with men are impacted, as well as transgender women, as well as female sex workers, and young women of color. Pre-exposure prophylaxis is just one armamentarium that's used to prevent against HIV. There are many others that are listed here, and we're going to talk about oral pre-exposure prophylaxis as part of the PUSH study. Why focus on youth? Well, particularly in the United States, there's been low uptake of pre-exposure prophylaxis, as shown here on the right-hand slide, only 11% at last pharmacy data suggested that young adults, adolescents and young adults were actually prescribed PrEP. And that's disproportionate to the percentage of youth that are impacted by HIV. There are even more racial ethnic disparities in the United States, and what you see here, I don't know if this is a pointer, but in these, in the first slide are the number, in the first bar graphs are the number of PrEP users, and if you break that down by gender or sex, then you see that African Americans are disproportionately have lower rates of PrEP use here, as shown in the dark blue, and female PrEP users are even non-existent. So how can we engage young men who have sex with men and trans women to pre-exposure prophylaxis? The PUSH study, which you've heard about a little bit this morning, is entitled Providing Unique Support for Health for Young Black and Latino Men using a mobile enhanced engagement intervention. And it includes gender nonconforming as well as transgender women. This name, PUSH, came from feedback from youth that they felt like they were looking for an intervention that would be able to provide them with some unique support. And they really thought that that was a message to be able to send to other youth, that through this intervention, they're pushing forward, they're moving forward together. These are our collaborating partners. So we have partners in DC at Children's National, Whitman Walker, and then also at Children's Hospital of Philadelphia. What I want to show you is really that these particular cities, particularly Baltimore and Washington, D.C., have some of the highest rates of HIV in the United States, as shown here in this map. And we actually happen to be below the Mason-Dixon line, which is, so we're considered in the South. So who do we target for PUSH? As I mentioned, we focus on Philadelphia, Baltimore, and Washington, D.C. Our age range is 15 to 24 years old. We focus on African American and Latino youth. And we originally started out focused only on African American youth. And what we heard from our key informant interviews is that there was so much overlap between youth that identified as being of color, right? So African American youth were having a hard time separating their identity of being African American from being Latino or Latinx, right? So that there was so much overlap within the community that they thought it would be unreasonable to separate them according to those race ethnicities. And then we focus on men who report sex with men, that's cisgender men who report sex with men, as well as gender nonconforming and transgender females. So in this population, we focus not only on youth that were at risk for HIV, but also youth that were living with HIV. So we recruited youth that had a viral suppression of greater than 200. And then anyone that was HIV uninfected and reported having had prior anal intercourse in the last year without a condom. In addition, anyone who had reported any sexually transmitted infection. We used a broader risk criteria than the CDC criteria so that we could try to reach as many youth as possible. And we're actually in the process of even expanding this even further. So Dr. Andrea Woods spent some time talking about our recruitment strategy, which we've used deep chain respondent-driven sampling, or a modified respondent-driven sampling. We really had those sprouts that you saw. We really didn't get into real deep networks. And so we've actually had to also increase other aspects such as social media, as well as clinic recruitment and venue-based recruitment. So this is an example of some of our recruitment flyers on social media pages. And I'm gonna try to go here and see if I can show you our, show you our web page so that you have an idea of what that looks like. because I think that what we've tried to do, we've worked with our chat partners who actually have a lot of experience doing online recruitment to really try to use Facebook. And so what you see is that these are just examples and posts that our team have used to make things relevant for youth, to make it relevant for them and their community. So particularly interviews or media feeds. And then also what you see at the bottom is we have quotes and just discussion points and about items that are relevant to youth. And I don't know how much more that, I think that's it. This is just an example of how you can make a website actually more relevant for youth and what we've used in our project to draw in the youth onto our site. Let me see if I can get back to, okay. We've also partnered with area prep programs, and I'm just highlighting our prep program here, and we do a lot of community outreach and a lot of community events. So we do tabling, we're part of the house ball community as well as the house ball programming. We provide pool parties, we try to get youth involved in our youth advisory board that has youth specific events. And so I think you have to be creative. Just to sort of go back to what Andrew was saying earlier, responder-driven sampling for youth has been slow, right? So it's been slow in our population in Baltimore, in DC, and Philadelphia. I think it takes multiple strategies. It takes actually using social network recruiting, web-based recruiting, clinic-based, as well as venue-based recruiting. And as a result, we've recruited 281 participants to date. As you can see here, this is a very risky population as far as almost a third are living with HIV. Over a quarter had described transactional sex or exchange sex. And we had actually a number of youth that actually were gender nonconforming trans identified. And just to highlight that we found that transactional sex or exchange sex, sex for housing, resources, etc., was quite common, and that a lot of youth described having been forced or coerced to engage in sexual activity or sexual acts, or having been forced to engage not to use condoms during sexual activity, as shown here. And we had very high rates of marijuana, as well as alcohol and other drug use. Particularly of note that individuals that had engaged in, had been engaged in transactional sex were more likely to report using other substances, such as methamphetamine, opiates, and sedatives. So from there, we actually have approximately 125 youth that have actually been randomized to our intervention. And so I'm going to spend the next few minutes talking about our coach-based intervention. And so we randomize individuals 1-to-1 into each arm. And the coach-based intervention is basically a coach, a peer coach, that is someone from the community that's close in age to the individual. And they actually communicate with the youth via a mobile application. And so I think what's nice is that Tanya really talked a little bit about an application, a mobile app, but what's innovative about this strategy is that there's actually a live person on the other end. There's a coach that's actually working with the youth, trying to establish their goals and focusing on their health behavior. And so here's an example. They log into the first screen, and then they actually can identify what their needs are, whether or not they need support around appointments, around medication reminders, and we've added on a video chat feature so that they can actually chat with one another through video chat. And so the youth are really they're using multiple strategies, text messaging, video chat, through the application to actually engage with their coach around support. We also, because of the high rates of substance use, have a substance use survey that is actually included. And so this way we have more detailed information about the amount of substance use they're engaging in and how that might impact their uptake of preventive and treatment on a day-to-day basis. And so here's an example. We ask a series of questions around alcohol as well as marijuana and other drugs. And then we give some feedback. So great job. This is a strength-based approach. So as individuals at their first visit, they identify goals and they identify what their target goals are. We find that youth actually are not identifying that taking their medication is a health goal. Right. So this is kind of interesting. I think that this is where we often miss the boat because we feel like, oh, well, you must be interested in taking medications. You must be interested in taking PrEP. You must be interested in taking condoms. And when you ask them what their hierarchy of what they're interested in, it's not that. Most of the youth are describing that they're more interested in finishing school, finding a job, finding housing. And we're starting to see that youth actually, once they accomplish that first goal, they're coming back to a health goal at a later time when they follow up with the coach. But their first goal is not necessarily taking medications or adhering to PrEP. And I think that's really interesting because then we can incorporate some of these other goals and other risk behavior as they're following through. And so what does this coach engagement look like? So we really modified it to be a stepwise approach so that depending on your level of need, determines how much support you need. So whether or not you need daily messages or weekly messages to just a weekly check-in to as needed check-in. And then having face-to-face meetings, using a strength-based approach, focusing on goals, and then motivational interviewing to engage the youth into care. And so when we asked coaches, coaches described that 75% of their participants were communicating regularly, and 25 were communicating less regularly, so not very consistently or not at all. Because of the approach that we're using, we can't say that those individuals are not necessarily not interested. They may just be have a low requirement, and they don't need every day or weekly engagement. So I think the point of that is that one size doesn't fit all adolescents. So some adolescents may need and require more intensive support, as well as others may not require as much as support. We have noticed that our coaches refer and link individuals to the clinic, but they're also providing other wraparound services. And so coaches describe that some of them, they have to help with housing, and they do some case management, but other coaches are really just working with the youth to encourage them to actually reach their goals. And so it's flexible so that it depends on what the need of the youth is. Why a health coach? So this is what we heard from our key informant interviews. We really heard, and I think this builds on what Taiwanese talked about earlier, the need for confidential support from someone who was similar to them and just feeling like they had someone who could provide that confidential support. So this person says, I think that it would create a sense of confidentiality so they would feel more secure sharing all the details because, you know, sometimes you can be engaged with the youth and they can only tell you half the story. So having sort of trust and connection, that what I'm saying to this person is completely confidential. They're a health coach assigned to me, so I know I won't have to worry about all my business being spread around to other folks. And so I think that that person's really describing that a health coach, a person that is actually very connected to them, that's providing the safe, confidential space, is just that, is someone that they could trust. And so this other person describes that they actually need some support. So and it shows sort of the breadth of what's needed. So this person describes the need for monitoring, the need for someone to check in on them, because I guess it would make me feel good that someone is helping me and keeping me on track. If I can't do it by myself, and then it's being acknowledged for doing it. So I think just having that person that's there, that's helping them to keep on track, and then acknowledging them for doing what they're doing, being engaged at whatever level they are engaged, whether it's low or high, actually provides some motivation and encouragement for youth. I want to just talk about a couple of other strategies that have been used, particularly in Baltimore, to reach young MSM. So Dr. Errol Fields has done some safe spaces work. And so he's used mobile HIV testing to actually engage youth into getting tested as well as getting access to PrEP. So he's worked with the Baltimore City Health Department and has had used the geo-targeted ads so that individuals are actually provided messaging on these sites and then directed to a website and told where a van is located so that they can go in the community and be tested and access PrEP real time in the community. So I think this is an example of, they also use referral cards. So it is an example of how you might be combined sort of the venue-based approach and the community approach with referral cards and what might work. And so they found that, I know earlier, Allison, you mentioned that some of the youth from the panel said, don't be on our site, and really concerned about the flooding of Grindr or Jacked. They found that some of these very marketed advertisements on those sites has been effective to get people the information they need around where the testing ban is, because it's viewed as more of a community prevention approach rather than a research approach. So I'd like to acknowledge all of our co-authors and team members, as well as our funders. And just to remind people why we do this work, I think that these represent a number of the youth that we care for in our community. And this strategy really tries to meet the youth where they are using a strength-based approach. So it's really centered around the youth's goals, and then trying to leverage those goals to get them into care and into preventive services. I'll end there. Thank you.
Okay, why don't we take a couple of questions, and then we'll give you a brief bathroom break, and then we'll turn over and go into our panel. Okay, go ahead. Questions? Tanya Ray.
I'm interested in the coach engagement, and you categorize them into high, medium, low. That one was perspective of coach or perspective of the client who say that what level that they need for the coaching.
Yeah. So it's really the perspective of the client, right? So the coach's perspective may not necessarily match all the time, right? Because what we have them do is they do an initial needs assessment. The coach at the first visit goes over any key points of risk that they may engage around. And there are often a number of areas of risk, right? And so those individuals that are often high risk and need more support services may not themselves want to engage in intensive support. And so part of the motivational strategy is to get them to see that so that we can provide them with the more intensive support as needed. But we have to leverage, that's why we use a motivational interviewing approach, so that we can leverage them and their interest and really build on that to actually engage them into treatment and care. So it doesn't often match. Yeah, we haven't yet done the analysis to see how closely it matches, and this is just what we've heard from the coaches. Yeah.
Hey, Doc, I wanted to ask two questions real quick. One in regards to the ballroom, how effective have that community in helping bringing youth in and identifying them and being also peers, and the housing situation. We know that youth housing is, how closely are you working with the city health department and linking to care in the housing part?
Yeah, so great question. So the first question is that we have one of our peer coaches is part of the house community. And so he has worked with the house community. We've gotten feedback from the house community as to how to engage them and have started to, what the house fathers and mothers have identified is the need to have these spaces that are not necessarily only just mini balls, but maybe are nights where youth can come and then they can share their experiences. And there's this bi-directional sharing that goes on in these spaces to encourage them to get into care, whether it's mental health, substance use, treatment, prevention. And so have it be more of a thoughtful approach in these spaces, but where they can encourage their house members to come and be present. And so I think that there is a real opportunity there to actually be able to provide that space for those youth so that they know that it's not just voguing and participating in balls, but really how do we leverage that to get them engaged in care. We have had actually a number of house members refer people to the study because they felt like they could benefit from a coach. And so that has also been another benefit of working with the house community. And that's both in Philadelphia and Baltimore. As far as the housing, it's really been on an individual basis. So really if there's an individual need, then the coach will work with the local housing entities to try to link them into care around housing, but it's not we have not necessarily built a program around that.
All right, great. Another hand for Renata. All right, we are going to take a 5-minute bathroom break, at which point we'll transition to our panel component of this. Please, if you had additional questions for Renata or any other speakers, this is your chance to really pick their brains. Okay? All righty. So this is always the most exciting part of, to me, any of these symposiums is where we get to interact with the people who presented. You've met everybody here except for Imani Cole Robinson, who is actually one of my most fabulous people that I have met, young people. But I'd like to give him a chance to introduce himself, tell you why he is the expert in the room about what we're talking about, and before we launch into questions. So Imani, you're up.
Thank you, Dr. Agu. Good morning, everyone. My name is Imani Cole Robinson. I'm 26 years old. I'm actually turning 27 this Friday.
Happy birthday.
Thank you. So with the prep program, I want to say it was about like 4 years ago. Longer. 4 or 5, maybe.
Longer.
Really?
You were under 24, Imani. You were like 21.
No, I was 22.
Yeah, 22.
Yeah. So when I was 22, I had heard about the prep program, and I actually found out about it through a dating app, Jack. I found out about it through Jack, a recruiter. Had messaged me on there, and it's interesting because I'm not originally from Baltimore. I'm originally from Washington, D.C. And weird story, but my MD had like disappeared. So when this was kind of like I guess 2 birds, 1 stone type of situation, because I had never even heard about PrEP, and I also didn't have a current MD. So the MD that I have now, Dr. Sanders, I inherited her through the PrEP program. And it was interesting to me because before the recruiter reached out to me, I had never even heard about like Truvada or PrEP like at all, like not even remotely. So I had like a lot of questions. I was like, what is this? They were like, well, you have to be 18 to 23, HIV negative, gay male, and I was, at the time, I think I was like 22, so I had met the criteria. And the largest incentive for me, because at the time I wasn't currently working, so they was like, oh, we'll pay you for each visit. I was like, oh, okay, cool. So that's what really was my biggest incentive at the time. And so, yeah, as I was learning about it, I was like, okay, this is not a bad thing, because that was my first thing. I'm like, well, am I going to be taking something? Is it going to be like an injection? Because I didn't know what it was at all. But as I learned about it from each visit, I was like, okay, well, this is not a bad thing. This is actually a good thing, especially for somebody like me who has high risk behaviors and stuff like that. I even tried to refer a couple of people, but what I noticed was the referral process, I want to say, is very jarring, because one person I tried to refer was actually my best friend at the time. I tried to refer him, and he was like, oh no, I don't want to do it. And he was like, John Hopkins has all these like weird, I guess, superstitions and stuff. And stuff like that to me doesn't make logical sense. So I'm just like, okay, no, you sound crazy, but whatever. And then another person, I tried to refer. One person said yes, the other person said no. He was like, he didn't want to do it because he felt like a lab rat. And to me, I was like, well, that's a state of mind, but okay. Like, so yeah, I did the program, and even after it was over, I continued with the medication, and mainly because they had actually helped me with co-payments, because that was my biggest issue. I was like, well, after the program is over, I'm no longer going to be getting it for free. So how would I go about paying for it? Because I eventually gained employment, but I wasn't making that much money, and they actually helped me with resources for co-payments and stuff like that, because my insurance did not cover the entire amount. So the co-pay part was very important. And I also wanted to talk about a particular incident, because a couple years ago I was in a long-term relationship, and my boyfriend was at my apartment, and he had stayed there. I think I had went to work or I went somewhere, and I let him stay there while I was gone, because I don't think I was going to be gone long. And I came back, and he looked kind of like shocked or confused, or I don't know. And he just pulled out my Truvada bottle, and he was like, "What's this?" And in my mind, I'm like, "Oh shit!" I'm like, he's panicking for no reason. So now I'm gonna have to explain this. But I'm actually glad that the incident did occur, because in my mind, I had actually never even thought to even talk to him about it, because I was like, well, I'm HIV negative. I take this pill every day for preventative measures. So in my mind, it wasn't a big deal. I was like, because I'm doing this for the benefit of my own health. But then, yeah, it brought up the topic, well, maybe I should talk to people, or maybe I should tell people about it, or make people aware or privy to me being in the prep program and taking Truvada and stuff like that, because he was like really panicking. Like, he was like, oh my God, what's this, what's going on, blah, blah, blah. And I basically had to explain it to him, and I was like, I've been on this program for a while, like way before I even met you. But like I told him, it never occurred for me to talk about it, because it was a good thing and for preventative measures. And actually, when this whole discussion started this morning, a image had came to mind that I had shared with Dr. Sanders, the image that you see here on the screen. And basically, because I'm on social media, I'm on Instagram, I have over 2,000 followers. And this image here, is anybody in the room familiar with RuPaul's Drag Race? Mm-hmm. Okay. So the image here, the drag performer that's on the right, goes by the name of the Vixen. And on her season of Drag Race, she was a very controversial contestant. And that can be a good and or bad thing. But I follow the Vixen on Instagram. And with this image, I thought this was one of the most magnificent things that I had ever seen, because even with her being so controversial, people are going to look at her. So then when you post an image like this, they're going to be like, what's that about? Mm-hmm. And so basically this image, the Vixen on the right, who is HIV negative, has on an abstract gown with the, Truvada pill. And her partner on the right, he's HIV positive. And he also takes a pill, which would be the green pill. And so I was like, wow, what a great way to, get people talking about something other than your, controversies on Drag Race. And I thought this was so great because, like I said, she was so controversial. So it's like you want to get more eyeballs, you want to get more focus, more attention on something positive, because people are going to come to you as a public figure, and try to nitpick and look for any little thing that they can pull. And so I feel like when you put up an image like this, it's like, no, I'm more than what you saw on a TV screen for 15 minutes. And I feel like we need more images like this from public figures who are, catapulted into like stardom, like overnight, like a Drag Race contestant, a reality TV contestant, or even much larger celebrities. We need more people talking about it. And the image more so related, I could relate more to it because I'm a gay Black male, and the Vixen is a gay Black male. And I felt like more relatable images are needed, more relatable images, because we can't just always have, for lack of a better term, we can't always have the hunky white guy. We can't always have that image. Well, because for one, it's not real, it's not relatable, and we've seen it already. We've been seeing it for forever, pretty much. So yeah.
Told you Imani was cool. So Imani, you describe your experience today as somewhat like the people who were in Chris's campaign with 95+% adherence, sustained, persistence. And I'm curious from your perspective, and then I'd love to hear others' thoughts, how we can, the goal here is to get more of our young people to look like you, and what made the difference, and what can you tell the researchers and the people trying to get PrEP to young people would make the difference to get more people on?
Well, I guess what made me more comfortable, I've had an MD my whole life. And so I guess what made me more comfortable with the process was that when I did get recruited, I got recruited by another young Black male. And so that made me ease into the process a little bit better, because like I said, I had never even heard of PrEP until a recruiter reached out to me. So that made the process a little bit better. And then even when I got here, they asked me, well, what type of doctor would you feel more comfortable with meeting? And I told them I preferred like a black female doctor. That was my preference. And they said, okay, well, we can arrange that, because I also feel like when it comes to health, it's all about, I guess, making a patient comfortable, because you have to build a rapport and you have to build a trust, you know, and confidentiality with, you know, doctor-patient, nurse-patient, and stuff like that. So, yeah.
Are there questions? I don't want to hog all of them, so any questions? So, Carlton?
So thank you for sharing. And between your adolescent until you found out, how important was it for you to find a doctor that you could relate to? And you spoke of, which I'm glad that I heard it and other people may have heard it as well, the relationship that you have with your doctor. I know for myself how important that is. So could you expound on that and on that relationship?
Well, for me, I've always had an MD my whole life. So the relationship, I guess, with my doctor is very important for me in particular. Even though I'm a gay black man, my whole life I've been raised by black women. From my mother to my aunt to my grandmother, to my older cousins who are like more my mother and my aunt's age. And so when I got here, when they asked me, I was actually surprised when they asked me, what kind of doctor would you be more comfortable with? I was like, I would be more comfortable with a black woman, being the person that I go to. So regularly I will always see either Dr. Agu or Dr. Sanders. And then eventually Dr. Sanders became my my primary care physician. So.
Question.
Could I just make a comment as well,
Yeah,
Allison?
absolutely.
So, yeah. Just on the issue, one of the things you mentioned, Imani, was that when you were starting at an early age, that the financial incentives mattered to you.
Yeah.
So that's something, you know, we're are thinking about and grappling with a little bit with this TIE study, because the Ministry of Public Health sets the incentives, and they're pretty high, and they wanted us actually to incentivize every visit, including the PrEP pickup visits. So, you know, that looks great, but the question about sustainability and generalizability is really, really a big issue when you get out of a research agenda and more into implementation. But in your case, there was a financial incentive, and it made a difference to you as a young person. So I think that's important to, you know, think about.
Yes. Actually, just to add to that, to the 110 study, I mean, there was incentives in terms of visits. You know, it was like, I think $30 or $45 per visit, but we also helped transportation, et cetera. And while they were there was, you know, you got a doctor. Like when I'm saying, you had screening, you had referring for things, someone who's tending to your other needs. And then people could have the option to do some things at home and they would still come in, right? So there was some additional benefit that I think moved beyond financial. And what I hear Imani speaking to is asking the youth what they want, right? And involving them early, because a lot of times the researchers, we design these studies and they're like, well, I couldn't care less about that. I really just want this thing. You know, involving them early and involving them often. So go ahead, you're going to make a comment, I think.
Yeah, and I just wanted to say one other thing. I feel like studies like this are needed and they are important, because like I said before, I was reached out to by the recruiter. I had never even heard of PrEP and things like that. And at the time I was 22. But when I was, I would say between the ages of 18 and 19, I did used to participate in sex work. I did used to escort back home in DC. And even like back then, I didn't really have any like real support because in my family, I want to say that I know of, I'm the only gay person in my entire family. And I never even really grew with any gay friends either. I want to say in my high school, there was about 4 of us that were openly gay at my high school. And so back then, I want to say I was just living a very experimental life because I didn't really know where I fit in or how I would take care of myself. Because my family, they have a certain mentality. We call it get it how you live. And basically you have to go out here and you make a way for yourself by any means necessary. And I feel like it's very unfortunate because even with a situation like my mother, she's a lawyer, very successful, probably one of the only few people that even have a degree in my family. And even with her, as I was getting older, any help from her was getting limited, like it was shrinking. And I want to say by the time I turned 18, it was like, all right, what you gonna do? You gotta figure it out because I made a way for myself. Now you gotta figure it out. And so she did, but she made it very clear to me that I would not be able to stay on her insurance. So I was on her insurance. I was on her insurance, but yeah, she made it very clear. She was like, "You cannot stay on my insurance. You can't live with me. You can't do this. You can't like just a laundry list of things that were no longer going to take place."
Can I just add?
Yeah.
I think from a provider's perspective, I think this is why, I do what I do because, a lot of the youth are displaced because of their sexual orientation, have to resort to transactional or exchange sex in order to survive, have other priorities, right, that are not necessarily PrEP, right? And so we've got to focus on how do we address all those other priorities first before we can even get to PrEP, because we're coming at it as we got to get on PrEP, and they're coming at it, I'm trying to survive, right? So I think that there is this disconnect in a lot of ways, and I think one other thing that Amani sort of alluded to, even if you want to get on PrEP, there are these insurance barriers, there's confidentiality barriers, there's consent barriers if you're younger, that actually can create barriers to engaging around PrEP. I mean, even with his insurance, he had very high copays, right? And it's at one point, he lost insurance because of what he just described. And so then our team, this was no longer an ATN, project. This was now in real life. Our team had to really spend a lot of time trying to get him PrEP and get him, pharmacy assistance programs so that he could actually receive that PrEP service. And so that takes a lot of time. And a lot of providers don't have the capacity to be able to do that. They don't have the extra staff that can spend, or a social worker that can spend time calling around and getting things covered. All that takes time. So there, I think, a lot of structural barriers that just impact one's ability to get on PrEP, in addition to some of the other things you talked about, like mistrust and stigma, fear of someone finding the medicines and stuff like that.
So first of all, Amani, thank you so much. I really am grateful in your courage for sharing your story with us. I really needed to hear that. So I just wanted to comment and then ask a quick question of the panel. First, I noticed this image is very visually arresting. It's like eye grabbing, but it doesn't say the word HIV anywhere on there. It just says the vixen is so negative. Why? She takes her PrEP daily. Her boyfriend stays positively undetectable. And I was wondering if you could comment a little bit about if somebody is unaware of what PrEP is or is unaware of, is not in that context, how this image might reach them and inform them about PrEP. And then kind of to carry off of that, the question for the rest of the panel is, when you're doing your advertisement and you're working with your social media influencers and whatnot, was there anything that surprised you, or you were, your partners wanted to take it in one direction, you're like, I would have never thought of doing it in that way, but it ended up sort of working, whether that's something that you were doing in Thailand that might not have worked in the US or vice versa, or just something generally unexpected?
Yeah, I want to say with the image, for me, yeah, even though it doesn't say anything about HIV, in particular, the image still grabbed me because even with the caption, because I know they're, I guess, I don't want to say ignorant, but I want to say they're probably less informed people that are not as informed as I am. And so somebody could probably read the caption and be like, oh, well, how is this possible? How are you, how are you still negative and you have a positive partner? Somebody might think like that. Me, I already know the answer to that. But somebody else, like I said, who might be less informed, when they read the caption, they're going to be like, okay, well, how is this possible? They may think to themselves, I don't know how this is possible, so let me read upon it or let me ask somebody. I feel like, somebody might have that standpoint versus me, who's more informed. I'm like, wow, what a great way to start a conversation, especially with, like I said, with this contestant in particular being so controversial on their season.
Other comments, the panel?
So in terms of social media or ad, so what I talk to adolescents is that they don't want too much information. Mm-hmm. They just want something that is attractive or make them think about what is it, and they would like to trace information. So when we have a PrEP campaign in the community, at the beginning we think that we would provide some information about PrEP and how to get it, and they say that no, you just give up the blue pill and say that PrEP, and that's it, and then they will caught at their attention and they will follow what is all about and how it's related to themselves. So I think it's different way of thought when we try to engage adolescents and have to ask them which way that will get their attention.
I guess I would just add that we were a little bit later in the rollout, and there were a number of programs underway, but many of them you have to pay, or you have to pay some amount of money. So one of the things that emerged from the formative work was that a way to access PrEP for free was important to people. And that was then a challenge for the IRB. They didn't want it to be perceived, that we were, so we had to be very explicit that we were offering a comprehensive prevention package for free, and that could include PrEP or not. But in the end, all the materials make it very explicit that this is a way to get PrEP for free. And again, because these guys and the trans women are selling sex, are sex workers, they're generally people who really need resources. So that matters.
I agree with all those comments, and I would also follow with a comment that one of the I think, challenges of online recruitment, online advertisement, social media is that inherently the amount of text and language that you can provide in your advertisement is very limited. So you get 1 or 2 lines, a certain number of characters. So you actually have to convey your message either through a short video clip, through the photo itself, something that's just visually appealing and will draw people to that information. So that's typically, I think, kind of where a lot of these directions have come from, is just an inherent restriction of the text and the information that can be provided. I think, in addition to providing something that's kind of visually appealing, attractive, it's gonna lead people to wonder what you're sort of talking about with that message that's in your photo, is also making sure that your photos are representative of the population you're trying to reach. And that, for some populations, that's quite diverse. And that takes a lot of work in and of itself to identify kind of the range of photos and images that you can create that helps you to reach a very gender diverse population, a very racially diverse population. And in terms of research, that's added work with your IRB. So we, for example, when we do our IRB amendments, we submit a zip file now of all of the images that we want to prove, because you have to constantly change your images and keep it fresh for people to be interested in what the message that you're sharing.
Or use no text at all.
Mm-hmm.
Video.
And like I said earlier, the most effective ad that we had in Philadelphia was just 2 young men embracing, right? So and it was just about celebrating love, same gender love. And that brought people to the site to learn more about the study around PrEP, but it wasn't necessarily just focused, it wasn't focused on PrEP, it was focused on same gender love and how to create that space. And so I think you have to also just be mindful of your audience, of what they're going to be turned off by, and avoid sort of those polarizing images that sort of make some people feel uncomfortable and not welcomed, right?
I wonder if I could piggyback on something Imani said. Imani said there were maybe 4 people in his school that were identified as gay. So imagine him having a ticket that he has to then go identify for responding for RDS, that wouldn't necessarily work as a strategy, because let's say he wasn't identified, now he's identifying himself, and maybe he was wrong. So you could see just from you talking about it that wouldn't be a strategy. I'm curious from the app perspective, because everybody. Ooh,
that's what I want to talk about.
Okay.
Speaking of apps, because I actually did have a question earlier, but I just wanted to wait. I actually wanted to ask the rest of the panel, do you feel like with these dating apps in particular, do you feel like the diversity is a big barrier? Because I feel like certain dating apps cater to certain ethnicities more. Like I feel like with Grindr, it caters to more of I guess Caucasian males. With Jacked, it caters to more of African American, Latino males, and transgender females. And do you ever feel like, because sometimes I feel like with these apps, they kind of isolate the ethnicities a bit. So it's like, no, you can't go to one app expecting to hit every ethnicity, because it just doesn't work that way. So I want to know, have you guys experienced that as a major barrier, or it might be a minor barrier? I don't know.
Well, just say with the Thai data, I didn't show it, but we analyzed, what apps people used and which ones were most successful with recruitment. Actually, Hornet was the most successful in the Thai context, and they have a program there. It's very explicitly Thai language set up, working for that community. What's a challenge for sex workers is that some of the apps still, are very explicit about excluding sex work or advertisements for sex work. So you end up in a sort of in a challenging environment there. But I don't know about how it goes with light. It wasn't so helpful for you, right? Using apps specifically.
Yeah. So as I mentioned, the dating apps were not quite so successful for reaching transgender women, and I think you raise a very valid point about there are dating apps for different race ethnicities. There are dating apps for kind of different ways that people identify. So there's kind of like the daddy dating apps, and like there's one I just saw that was like the bearded men dating app, and there's kind of like a new dating app every day. The other perspective of it, so it's a great point that you have to, if you're trying to have a very diverse population and reach a diverse group, you have to reach out through a number of different dating apps. On the other side of it as well is there are certain apps that are open to that and others that are not. So for example, Grindr now has a policy that they really don't engage with advertisers unless they're willing to spend over $50,000. So from a research perspective, that's really kind of like a non-starter. If you try to advertise at a price below that, you're competing against other bidders, and they have a no guarantee policy which says that if there are other people that are paying higher than you that particular day and for that geolocation, you'll pay, but you might not have an impression show up. So there are a lot of issues to navigate, both I think on the perspective of who you're potentially reaching through those dating apps, and that is a really important point I think that you raise. But also then on the other side of, so you might identify, okay, this is a study for young Black MSM, and so we'll work with Black Gay Chat or work with a number of other dating apps that would be more specific for that population. But whether those apps are open to advertising at the levels that we can actually afford in research, or if they're open to advertising at all, is a different question. So there's a lot of considerations and sort of balancing that you have to do and research that you have to do to be able to even think about working with the dating apps.
I would just say that we have not been very successful in recruiting on Jacked. We had in a prior study, but then I would say yes, right. That's right. But more recently, because we were using passive recruitment during that time where we post the information about the study in order to actually do active recruitment, as Andrea described, you have to pay. And so we have not used Jacked, and with the passive recruitment have not actually had people identify that way to access the study. So I think that we're just rethinking things. We're using much more Facebook and going to Instagram and stuff like that. So.
All right. Go ahead.
I think for Thailand, it's not diverse in terms of ethnicity or race, but it's in terms of the education level and also rural or urban settings that there are different access to app. And for example, we have a group that have out of school or in the street that they are not quite using application. So what we found is that the different population that we reach from online or from the app or from the referral or from the clinic settings is quite different populations. Yeah.
All right. Any last questions or comments? I realize we're over a little bit and the food is there and people are hungry. Thank you guys so much for your speeches, and Imani for your story and for really educating us. I mean, that's why we're here. Please, one last round of applause for everybody. And thank you for your attention, everybody.